So, good morning, everybody. Welcome to this annual virtual MDT we're doing for a couple of years now. And thank you for being here with us. We have two enemies today. One is the weather, because it's a perfect weather here in Greece. So most of the people will actually have to waste this day, waste in brackets, to be here with us. So we thank them for that. And second, the time. We have to run after time. So we have to be very accurate to what we're doing. And this we're going to try to do. I will have the chance to talk to you later on the briefing. So now I will ask Michalis, Mr. Kondos, to welcome you all here. Michalis.
Thank you, Sophocles. Let me correct you. It's not a couple of times. I think it's the fourth or fifth time where Hellenic Society of Breast Surgeons organized this webinar, and I guess that it won't be the last. We'll have the chance and the opportunity to enjoy it in the future as well. And I'm saying this because of the success we've had it up to now. So thank you everyone for finding the time on a sunny Saturday morning to join us in this webinar. I guess this is the case because we're all alike. Not only we're clinicians, but we find it useful and interesting to discuss these borderline cases. These cases which are not provided for in the guidelines, and where there's no correct or wrong answer, but the truth is somewhere in the middle. And this is the cases where the interaction with other colleagues becomes even more useful and interesting. So for that reason, we have invited this year, and we did this, we've been doing this for a few years now, colleagues from abroad, colleagues from different working backgrounds, different environments, and colleagues treating different populations with different habits and mentalities. And it would be very interesting, and we'll find it very interesting to hear what is their opinion on the presented cases. And not only this, but what we'll do is we'll ask for the opinion of the audience. And this is why this webinar is so interactive. So every question, after every question, we will wait and see the voting of the audience, what the attendees believe on every case. I would like to thank PCR and Mrs. Eleni Halividou, Laida Parigori, and the team for their invaluable help in the organization of this webinar. And of course, Mr. Michalis and the others and the whole IT team who have been very patient with us and helped us organizing this webinar. So I won't say anything else. I would like to wish everyone to find this meeting useful, interesting, and enjoyable.
Well, I would like to invite Mr. Venizelos, the president of the Hellenic Society of Breast Surgeons, to welcome you all in this webinar. Vasilis.
Thank you very much, Sophocles. Good morning to everybody. I would like to thank you for your participation. Is this, as Michalis said, the fifth summer meeting of the Hellenic Society of Breast Surgeons. The previous meetings have been very, very successful, and I'm sure that is going to be the same this one. I would like to thank all the participants. We have a distinguished panel of presenters and speakers, and I'm looking forward to this meeting. Sophocles, the micro. Thank you very much to Sophocles, to the Vice President of the Hellenic Society of Breast Surgeons, Dr. Sophocles Danidis, and the Professor Michalis Kondos, for their effort to organize this meeting. Sophocles, the microphone is yours. Thank you very much again.
Thank you very much. My role is to do the briefing now for everybody, briefing from the presenters, briefing from the attendees, and briefing for the panelists. So this is the story in this case. We're going to have some presenters presenting a case, and then at some certain points, we're going to stop and have a multiple choice question. At that point, you're going to get a voting poll on your screen. You can move the poll around with your mouse, so in order not to cover the question. You'll have the time to think and answer on that question. Please don't be shy. It's anonymous. So please be free to answer your question. It's valuable because our panelists need your input to discuss the options. Okay? So it's very vital for you to vote. We need your vote, and we definitely need you to participate in this because your vote is going to direct us on our discussion. After getting the voting results, we're going to get those on the screen next to your question, and then our panelists will be called to discuss your answers. So you will know why your answer was the most appropriate. It's not a wrong or right in these answers. All of them are right. So they will discuss why this and not that, and why that's better in this case and not that in the other case. As you know, we are in the tailor-oriented medicine now, so every case is different, and this is what we try to pass in this session. Okay, for the presenters, as soon as they decide to get the poll results, they can ask the IT people to get them the poll results, and then me and Michalis will take over and give some of the panelists the stage for discussion. After completing each case, we're going to move to the next one. We'll try our answers from the panelists to be short, so as to be okay with that time, and to cover as much as possible of the available options. And at this point, I would like to welcome our expert panelists who are going to discuss the key points of this case. As you will find out, and as Michalis said, we have lots of different backgrounds, so you're going to listen to different aspects of the same thing. So for the first part, I'm privileged to welcome our medical oncologist, which is Ms. Karima Wala from Morocco and Dimitris Trifonopoulos from Greece, our radiotherapy oncologist, which is Mr. Dimopoulos, and our breast surgeons, which is Christos Markopoulos, Vasilis Venizelos, George Metaxas, and Thodoros Kondoulis from Greece, and Amit Agrawal from UK, Konstantinos Zacharidakis from the UK, George Exarchos, again from UK, also Panagiotis Hortis, and Urvashi Jain. So for the second part, we're going to have a new team taking over, but some of them may appear in the first part. We're going to have two more radiology oncologists, Mr. Skarlos and Mr. Maragoudakis. We're going to have two more medical oncologists, Ilias Koteas from Greece and Vasilis Angelis from the United Kingdom. And finally, going to have a couple of breast surgeons from everywhere, Marius Tasoulis from the United Kingdom, Andreas Karakatsanis from Sweden, Thorsten Kuhn from Germany. We have now Giuseppe Catanuno from Italy and Vasilis Karidakis from the United Kingdom. So thank you all for joining us. Thank you all for contributing to this. And before I start, I would like to thank the board of the Hellenic Society of Breast Surgeons for their support, the continuous support on this meeting that's happening every year. And of course, our sponsors who are making this possible. And finally, I would like to thank you all for joining and for appreciating our work and being with us this morning. So if you don't mind, we're going to carry on with the first case, and we're going to call on the stage Mr. Panagiotis Hortis, which I know from his junior years, but now he's actually a very good surgeon in the United Kingdom. And he's going to be very provocative because he's going to talk about inflammatory cancer, of course, the diagnosis and management, but mostly about whether we can do breast conservation in these cases. We all know that the current guidelines say mastectomy, axillary lymph node dissection, radiotherapy, and chemotherapy. So, Panagiotis, the stage is yours.
Good morning, everyone. It's nice to see you all. Let me share my presentation first. Okay, can you all see it?
Yes.
Okay, so good morning again. Before I begin my presentation, I would like to thank the organizing committee of this webinar for this opportunity to be among the presenters of this first section for another year. Especially many thanks and special thanks to my teacher and my mentor in Athens for many years, Mr. Lanitis, and also Mr. Kondos and Mr. Venizelos and the board of the Hellenic Society of Breast Surgeons. So I will begin the first section of this webinar by presenting a case that will give us the opportunity to discuss about inflammatory breast cancer, aspects of its diagnosis and management, aspects of the surgical management to the breast, and surgical management to the axilla. So the case that I'm going to present is about a 63-year-old postmenopausal patient who presented to our symptomatic breast clinic. The patient had been on regular annual screening until that time, and in fact, she had her last imaging 4 months before her presentation in clinic. This had been reported as unremarkable by the radiologists at the time. In terms of other medical issues, she had minor comorbidities, and in terms of family history, her mother was diagnosed with breast cancer at the age of 39, and her father was diagnosed with prostate cancer at the age of 91. The patient presented to the breast clinic with erythema and edema in her left breast, which she had had for a period of 1 month. She was given a course of oral antibiotics at that time, and subsequently, the erythema subsided, although she had persistent edema in her left breast. The patient did not report any nipple discharge or any palpable lesions in her breasts. The cup size was a C+, and on examination, there were no palpable lesions or masses in either breast. On inspection of the skin of the left breast, as you can see in the adjacent photo here, there was lymphedema and mild erythema in about 40% of the circumference of the left breast. And on palpation of the left axilla, there were 3 mobile palpable lymph nodes, each one of them measuring about 2 to 3 centimeters in size. Here you can see the external mammogram that the patient had 4 months prior to her presentation in clinic. This had been reported as M2 at the time by the radiologist, and according to the radiology report, there were benign lymph nodes without any abnormal findings from the breasts and without any significant interval change compared to previous mammograms. The patient additionally had an external bilateral breast and axillary ultrasound scan at the same time, which was again graded as U1 without any sinister or abnormal features from either the breasts or the axillae. Due to the discordance and the discrepancy between the clinical findings and the results from external imaging, we decided to proceed with a breast MRI. And the breast MRI did reveal a suspicious lesion in the lower outer quadrant of the left breast at 4 o'clock position, measuring 1.8 by 1.4 by 1.5 centimeters with irregular borders. And in the left axilla, it revealed the presence of 1 large abnormal lymph node measuring 3.5 by 1.9 centimeters, as well as other smaller lymph nodes, and marked skin and dermal thickening in the left breast. Now, in order to further investigate the abnormal findings of the MRI, we decided to undertake a second look ultrasound scan in our clinic, which in concordance with the MRI showed that there was indeed an abnormal breast lesion at 3 o'clock position of the left breast, measuring 1.8 by 1.4 by 1.5 centimeters. And you can see that in the first photograph on the left-hand side. By checking the left axilla with the probe, there was sonographic evidence of 3 abnormal lymph nodes, the largest of them measuring 3.5 by 2 centimeters in maximum diameter, as you can see in the second photograph on the left. And now it's time to begin the most interesting and important part of this webinar, because it's time for the audience to begin casting their votes and for our panelists to engage in the discussion of this case. So the first question that I would like to address to everyone is that in addition to the core needle biopsy of the breast lesion, that I believe we can all agree at this point that this is the next step forward, what else would you also recommend? Would you advise for fine needle aspiration from one of the axillary nodes, core needle biopsy from one of the lymph nodes in the axilla, a punch biopsy from the erythematous area of the skin of the left breast? Do you feel that since the diagnosis is likely inflammatory breast cancer, there isn't any need to obtain further cytology or histology from the lymph nodes, as the patient would likely need axillary node clearance, or from the skin of the breast, given that inflammatory breast cancer is mainly a clinical diagnosis? Would you advise for combination of FNA from one of the lymph nodes with the punch biopsy from the skin of the breast, or core needle biopsy from one of the axillary nodes with punch biopsy from the skin of the breast? So we can see the table for the voting. It's time to begin casting your votes now, and you will have 15 seconds in which to do that. So may we please begin?
Okay, just feel free to move the box around with your mouse if it's front of the question. If it happens to be on top of the question, just move it around so as you'll be able to see the questions. Take your time to decide. Please vote. We need your vote. Okay, shall we see the results, please? Okay. So most people voted number 6. Most people number 5. So they need a combination, and we have a split decision about the others. So I would like Mr. Markopoulos, would you mind discussing these answers and give us your feedback about what we should do and what do you think is proper in these cases?
Well, the questions here is to establish if it is an inflammatory cancer or not, and therefore the option 3 should be included. From the clinical appearance, I would doubt it because the erythema was reported to be better, and certainly we also need confirmation of the lymph node involvement. So I would say that both answers 5 and 6 are correct. I would go for choice 6.
Thank you very much. Does anybody believe that punch biopsy of the skin is useless in inflammatory breast cancer? I would like Mr. Exarchos, what do you think about it?
But you do call it inflammatory without evidence.
No, it's not a practice in our care to do a punch biopsy to prove lymphatic invasion. I'm not aware of any literature that can avoid it, to be honest.
Okay. And finally, I would like Mr. Trifonopoulos, just an input on that. Do you believe that you will need a punch biopsy to confirm the inflammatory breast cancer, or are you happy with the clinical diagnosis as it is stated in the NCCN guidelines?
No, I'm actually very fond of punch biopsy. I still think that inflammatory breast cancer is a pathological diagnosis. So I favor the punch biopsy. And also, as Mr. Markopoulos mentioned, the fact that she responded on antibiotics, again, moves me a bit away from the inflammatory breast cancer diagnosis. So yes, I do need the punch biopsy.
Okay, thank you very much. Panagiotis, can you carry on?
Yes, just 1 second, because I think I've
Just click on your screen and then you can
missed the
carry on.
presentation. Okay, so we decided to undertake a core biopsy from both the breast lesion at 4 o'clock position of the left breast and from the largest abnormal axillary lymph nodes. And at the same time, we decided to put 2 markers, one at the area of the index lesion in the breast and another one in the largest abnormal axillary nodes. And you can see in the last photo here that the clip was left in situ in the center of the largest lymph nodes in the axilla. So we decided to perform biopsies from the largest abnormal axillary lymph node, from the breast lesion, as well as 4 punch biopsies from the erythematous patch of the skin of the left breast. And histopathology from both the breast and the axillary node revealed the presence of invasive ductal carcinoma, NST grade 2. In terms of receptors and immunohistochemistry, ER was positive 100%, PR was negative, Ki67 was 20%, HER2 was 3+, therefore positive, and E-cadherin was also positive. And regarding the 4 punch biopsies that were taken from the skin of the left breast, there was evidence of inflammation in all of the skin layers without any malignant infiltration in any of the 4 specimens examined. So, provided that we've performed staging for this patient and there is no sign of distant metastasis for her, which one do you think is the most appropriate staging for this lady? T4D CN1 M0, consistent with inflammatory breast cancer, T1C N1 M0, T4D CN2 M0, consistent with inflammatory disease, or T1C N2 M0, consistent with a locally advanced tumor. May we see the table again, please? And you will have again time to vote, about 15 seconds. You may start doing it now.
So obviously here is a challenge between the clinical diagnosis and what we feel is appropriate, whether we believe or not that this is inflammatory cancer. I remind you that guidelines say that if it's the erythema and edema is more than the 1/3 of the breast, the punch biopsy is not mandatory, or it doesn't really prove or exclude inflammatory cancer. So can we see the answers, please? Okay, it's all split. So this is our point of this webinar, to have split answers. So do we have with us Ms. Karima Wala? Is she online?
Yeah, I'm here.
Good morning, welcome on board. So would you like to comment on this staging? What do you believe this cancer is?
Well, as you said, it's well, we know that the diagnosis of inflammatory breast cancer is mainly clinically, and I do think that you say that the involvement of the skin is more than 1/3, right, for the breast. So
Yes.
yeah, so if we want to make it easy, we can say, yeah, it's an inflammatory breast cancer, but sometimes it's challenging, and we do want to go for sometimes more conservative treatment and try to see the extension of the inflammatory I mean, skin, etc., to see if there is any possibility of the escalating surgery after. But anyway, for this patient, from the point of view of med-oncologist, it's a very good one to go for neoadjuvant. So that's sure. I don't think we will not debate about this, especially that she is HER2 positive breast cancer. But everything will depend on the type of surgery that we will decide on the MDT based on this staging. And I'm sure even in our MDT, we will be divided between pure inflammatory breast cancer and maybe some surgeons with us who want to push toward some conservative treatment when the inflammatory breast cancer is more localized. So yeah, that's the interest of this debate and those borderline cases. But definitely for me, so it's very clear that this patient will benefit from dual blockade, etc., and chemotherapy.
Okay, thank you very much. So most likely this is the problem with the studies based on the clinical diagnosis of inflammatory breast cancer, but I will not stick here. Let's carry on. Panagiotis, please carry on to the next question.
Okay, so we've discussed about the presentation of this lady, diagnosis, imaging, staging, and now it's time to move on to the management of this patient. So if you were to decide on the next step on the management of this lady, would you recommend for upfront surgery with modified radical mastectomy followed by adjuvant chemotherapy and radiotherapy, anthracycline-based, sorry, I've got a problem here with my computer, anthracycline-based neoadjuvant chemotherapy with concomitant anti-HER2 dual treatment with trastuzumab and pertuzumab, non-anthracycline-based neoadjuvant chemotherapy with targeted anti-HER2 dual treatment with trastuzumab and pertuzumab, or any regime of neoadjuvant chemotherapy with single administration of trastuzumab for HER2 receptor. Can we see the table again, please? Yes, and you may start voting now for this question, please.
I think Karima gave you a tip about that. So obviously you are a bit biased, but let's see what everybody's gonna vote on this one. Okay, shall we see the answers, please? Okay, so most people voted on answer 2, anthracycline-based neoadjuvant chemotherapy with anti-HER2. Mr. Trifonopoulos, would you mind discussing this?
Sure. This patient needs neoadjuvant chemotherapy no matter what. She got HER2 positive breast cancer, so we need the prognostic and predictive information of PCR or no PCR. So it is very important. Both choices, both anthracycline and non-anthracycline containing choices, are very good. They do achieve a high percentage of PCR. In previous studies, probably the highest PCR percentage was with a non-anthracycline regimen. I would favor a non-anthracycline regimen in this lady because she's over 60 years old and age is a major factor of cardiotoxicity from anthracyclines. And also, I would favor that because she would get the dual inhibition from the start of her treatment. Just an addition to the plan, I would make sure, because of her mother's history, that she would get genetic counseling. I would love to have that information before her surgery.
Okay, thank you very much. Karima, do you agree with Mr. Trifonopoulos?
Yeah, I completely join. I joined the previous opinion, and that the most important, the crucial is to put her under double blockade with trastuzumab. Pertuzumab will have the highest, rate of possible rate of PCR with this. Given the age, I also may be comfortable to the anthracycline, I will not be very worried about anthracycline, and we can achieve with trastuzumab, pertuzumab. Even with in the study, the Neosphere study, even by omitting all the chemotherapy and just by the double blockade, we had over around 17% of PCR. But for sure, I will go for chemotherapy plus trastuzumab, pertuzumab. No worry about anthracycline. And we will decide later based on the PCR outcome if we change the adjuvant anti-HER2 or not. And also completely joining about the genetic counseling, the mother and also the father with prostate cancer. So we should look for BRCA, but not only even the other genes.
Okay, thank you very much. Panagiotis, carry on.
Okay, thank you. So moving on, the case was discussed in our hospital's breast multidisciplinary team meeting, and the outcome was that the patient should undergo neoadjuvant chemotherapy, which was non-anthracycline based, combined with targeted dual blockade of the HER2 receptor with pertuzumab and trastuzumab. Following this, the patient had complete clinical and radiologic response. As you can see in the photo here, following administration of preoperative chemotherapy, there was no residual erythema or edema in the breast, which is consistent with complete clinical response from the breast, and there was no palpable axillary lymphadenopathy either. The patient had an ultrasound scan following her neoadjuvant treatment, which showed that only the marker could be visible in the breast without any underlying lesions from the parenchyma and without any enlarged or abnormal axillary nodes sonographically. Furthermore, the patient had an MRI scan following her neoadjuvant treatment, which again showed that only the area with the marker was visible in the breast without any identifiable underlying lesions and without any enlarged or abnormal axillary lymphadenopathy. So taking that into consideration, that following administration of preoperative treatment, the patient had complete clinical and radiologic response, which one do you think is the most appropriate step in the management of this patient from this point forward surgically? Does she need mastectomy and axillary node clearance, mastectomy and sentinel lymph node biopsy and targeted axillary dissection, wide local excision including the initial footprint of the tumor with axillary node clearance, wide local excision including the initial footprint of the tumor with sentinel lymph node biopsy and targeted axillary dissection, wide local excision including just the clip and its surrounding area with axillary node clearance, or wide local excision including only the clip and a surrounding rim of breast tissue with sentinel lymph node biopsy and targeted axillary dissection. We see the table again, and you may begin casting your votes, please, for this question.
Yes, so obviously here, first of all, you have to decide whether that was an inflammatory cancer or not. And secondly, you have to decide whether you initially excise the tumor, the footprint of the tumor, or just the area left behind after the treatment. And finally, you need to decide whether you believe on the central lymph node biopsy and TAD in these kind of patients with 2 or 3 lymph nodes involved, or whether you believe that axillary lymph node dissection currently is the most appropriate step in these cases. I'm going to give you some time here because it's quite complicated to decide, but please vote and please give us your opinion. Okay, can we see the results, please? Okay, most people obviously think that breast conservation is appropriate for this patient, while few people believe that this patient should have been managed properly as an inflammatory breast cancer. So now I would like Mr. Venizelos to discuss these choices, these answers, and give us his
I mean, I totally agree with Sophocles. I mean, we have to decide if this one is an inflammatory breast cancer or not. To be honest, I'm not convinced that this is an inflammatory breast cancer case. Therefore, because it's a T1C, and I strongly believe on punch biopsies, therefore these were negative. I will treat this patient as a T1CN2, and I will proceed because she had a very good and excellent result following the neoadjuvant chemotherapy. I will go with the choice 6. I will treat her with wide local excision clip and surrounding tissues, and I will perform sentinel node biopsies.
And target axillary dissection. Mr. Markopoulos, what do you think?
Yeah, I would totally agree with Vasilis, although I'm surprised that 1/3 of our audience believe that this was an inflammatory and they would go for mastectomy. I would do also a mastectomy if I was convinced. However, I would totally agree with Vasilis. I would go for choice 6. The question here is what are we going to remove? And this is, in my mind, a very important question. We do have a complete response. We only had one clip. So what we remove, the initial area or the clip and the surrounding tissue? Because if we go for the initial area, although this time we had only a very small tumor, then what's the purpose for in terms of the surgical excision, the gain of neoadjuvant? So I would stick for removing the clip and the surrounding area to the extent I feel something. And
Thank
I
you.
think this is
Mr.
something important to discuss also.
Theodori Gondoulis, what do you think?
Well, I quite agree with Professor Markopoulos and Mr. Venizelos that it's not an inflammatory cancer. But if we consider it as an inflammatory cancer, I think the only choice is number 1, because we know that the locoregional recurrence in an inflammatory breast cancer is very poor outcome. And usually, most of the papers that had wide local excisions in inflammatory breast cancer had cohorts that were not very representative of inflammatory breast cancer. They had a small nodal involvement, and they had almost always an underlying mass, which is easy to do a wide local excision. So if we consider it an inflammatory breast cancer, as the topic says, we should do a modified radical mastectomy. But I quite agree with Prof. Markopoulos and Mr. Venizelos that if it's not number 6, it's most correct choice. Thank you.
Thank you very much. Does anybody else of the surgeons has a different opinion? I think we covered everything. So I guess we can carry on, Panagiotis.
Yes, of course. Thank you. So the surgical plan from our team was to perform a left breast wide local excision with targeted axillary dissection and sentinel lymph node biopsy, plus or minus axillary node clearance if required. Dual technique was used for localization of the sentinel lymph node with both MagTrace and blue dye. And as you remember from our initial slides, before neoadjuvant chemotherapy, the largest abnormal lymph node had already been marked with a clip. In the photo here, I show you the X-ray from the surgical specimen that was taken intraoperatively, in which you can see that the clip was in the center of the specimen, adjacent to the guide wire that was used for localization, and there is a rim of healthy tissue surrounding the clip. We excised 4 sentinel lymph nodes, and all of them were negative for malignancy. All 4 nodes were hot and blue, and one of them did contain the marker that had been placed prior to neoadjuvant treatment. From the final surgical pathology report, we found that the wide local excision specimen, which measured 6.5 by 7 by 1.8 centimeters, included an area measuring 3 by 3 by 0.5 centimeters with elements of fibrosis and inflammation, consistent with treatment response, as well as the marker, obviously. There was no sign of malignant infiltration in the specimen. Therefore, that was consistent with complete pathologic response from both the breast and the axilla. And at the bottom of the slide here, I remind you the immunophenotype of the lesion initially from the breast and the axillary node, as demonstrated in the core biopsy. So the next question is about management of the axilla in this lady. And taking on board the status of both the breast and the axilla prior to administration of neoadjuvant chemotherapy, I remind you the debate that we've had if this lesion is going to be regarded as inflammatory or locally advanced, as well as the results from the targeted axillary dissection and sentinel lymph node biopsy, in which we excised 4 lymph nodes and all of them were negative for malignancy. Do you feel that the patient still needs completion axillary node clearance in any case, as there is no room for de-escalation and less extensive surgery? Do you feel that surgery to the axilla is complete, however, the patient still needs adjuvant radiotherapy to the axilla, supra and infraclavicular areas? Or do you feel that there isn't any need for any further management of this axilla at this point, apart from just routine surveillance and observation? So may we see the table again? Thank you. You may begin voting for this question, please.
I remind you, there are no correct and wrong answers. I remind you that the literature can support each one of these answers. And I remind you that most of the studies supporting some things are not mature yet, and we don't have the answers yet for that, about the oncologic safety and about the long-term results. I think this is a slightly difficult decision, so give them some time. Okay, shall we see the answers, please? Okay, most people voted in favor of radiotherapy to the axilla, suprainfraclavicular areas, and no further surgery. And some people are more adventurous, and they voted for nothing to the axilla, just observation. So I'd like Mr. Dimopoulos to give us his input on these answers.
Yeah, I think that in that case, we will treat anyway the initial tumor extension, which means that we will treat the axilla and the supraclavicular region plus the breast. And even if I think it's evidence level 2B to avoid axillary lymph node dissection. In the case of having more than 3 resected lymph nodes, I think we are on the safe side. So in my opinion, I would opt for choice 2.
Choose 2. So radiotherapy to the axilla, suprainfraclavicular areas, and no further surgery. So I would like Mr. Zachariadakis, can you comment on the surgical discussion here? Would you do any more surgery in this patient? I think Kostas may have a problem.
You can hear me now.
Yeah.
So I would definitely not do any further surgery. So there's no, if we proceeded with TAD or sentinel lymph node biopsy, and it came back as negative, and proceed with an axillary lymph node clearance, what was the point of doing TAD and sentinel lymph node biopsy? So you have 4 nodes, you have more than 3 nodes that are all negative. So I wouldn't do any further surgery. So if the plan was to do a clearance, it should have been done as part of the initial procedure.
What about radiotherapy? Are you happy with doing nothing?
So I actually voted nothing. So I'm in the adventurous group. So it depends. So radiotherapy to the supraclavicular fossa and internal mammary chain, our MDT would base that decision obviously in the pre-neoadjuvant staging. So now, if this patient had, I think, like up to 3 nodes that looked suspicious, am I right?
There were 3, yes, 3.
Yeah, so we would offer, it's a discussion, but yeah, we would normally offer radiotherapy to a patient that had more than 3, like 4 or more nodes that are positive. But I suppose it is, are we underestimating the axillary burden before neoadjuvant? It's a discussion. So I think like both answers would be correct. It depends on the clinical oncologist that gives radiotherapy. She would make the decision.
Okay, may I intervene?
Yes, of course.
I'm Vangelis Maragoudakis. Good morning, everybody.
Good morning, Mr. Maragoudakis. Welcome.
I would like to ask my friend Thanasis Dimopoulos if it is the time to de-escalate radiation to the axilla in case we have negative sentinel nodes. Now we have 4 negative sentinel nodes, and though I cannot insist that according to the guidelines, I think it's the time that we can de-escalate radiotherapy and exclude the supra and infraclavicular area, because we have complete response and we can cover the first levels of the axilla. And if we avoid the supraclavicular area, then we decrease the possibility of edema of the arm. What do you say about that, Thanasis?
I think that this is a future option, because what we have now at the moment from the data point of view is that we have the initial results of the NSABP B51, and we know from the authors that these results are immature, and these are the only data we have. And we have pronounced results for HER2 positive cancers, and this is at the moment also included in the NCCN guidelines, that we can take an individualized decision for avoiding regional nodal irradiation for such patients if they are HER2 positive. So I think at the moment we do not have the data to avoid regional nodal irradiation in patients with clinically N1 who convert into N0. So I think that after a few years, the results from the B51 might show that we can avoid it. At the moment, I think there is no such suggestion by the guidelines.
Okay, thank you, Thanasis.
Nevertheless, 33% of the attendees voted for no further management. Does anybody want to discuss that and give an opinion about not doing nothing? Anybody from the oncologists, radiotherapy oncologists, or surgeons? Does
Can I
anybody
have
want to?
an opinion, please?
Yes, George.
Thank you. Thank you. That's a very challenging case. I voted for mastectomy and axillary lymph node dissection in the first place, because I agree with all the comments from Professor Markopoulos and Vasilis Venizelos, and especially with Theodore Kontoulis. I think there is, from my point of view, there is a little uncertainty whether it is or whether it isn't inflammatory cancer. And in the case of uncertainty, I would go for more. I think that both mastectomy and axillary clearance would give us the optimum information also for radiotherapy treatment, because there is already a debate on whether we can de-escalate radiotherapy. I don't see any reason to choose number 3 in not doing any radiotherapy at all. So we have a group of patients that we have a little uncertainty, and we go from one edge, which is maximum treatment, surgical treatment, so mastectomy, axillary dissection, and full radiotherapy probably, to the other side, which is minimum surgery without radiotherapy. So that seems to be a little bit of a problem. That's my opinion. Okay.
Thank you very much, George. If we don't have any more comments, I think we should carry on. As you have seen, there are a lot of answers here. The most important to discuss these cases in an MDT and take the decisions based on the evidence and on the patient's preferences. So, Panagiotis, can you carry on, please?
Yes, of course. Thank you. I'm glad it was a provocative question for everyone. So this case was operated 5 years ago, at which time the evidence was not as mature and as robust as it is today, as we've already said. So we decided to proceed with completion of axillary node clearance in levels 1 and 2. We excised 14 additional lymph nodes, all of them negative again for malignancy. So in total, we had 20 lymph nodes, which were all clear. The patient underwent adjuvant radiotherapy to the non-dissected parts of the axilla, plus supraclav and infraclavicular areas following their clearance. I would like to also mention that it wouldn't be so easy to present this case today if we had not followed this patient up for at least 5 years since her operation, and if we were not confident that she remains disease-free up to this date. I've uploaded here the most recent mammogram of this patient, in which you can see that there is no mammographic evidence of local recurrence in this lady. And before we move on to the second presentation, I would like to draw your attention at the results of the 2 most recent meta-analyses in the surgical management of inflammatory breast cancer. One of them was from late 23, the other one from early 2024. And both of these meta-analyses have examined the oncologic outcomes regarding 5-year survival and local recurrence. and they have shown that there is no statistically significant difference regardless of whether the patient has undergone breast conservation or mastectomy in cases of inflammatory breast cancer with a good response to neoadjuvant chemotherapy. So given that the guidelines have not yet changed on this issue, I think it's an important take-home message and something that we can reflect on for the future. Thank you very much for your attention, and we can move on to the next presentation.
Just to give you another feedback about inflammatory breast cancer, I've just noticed that a randomized controlled trial is recruiting in the United Kingdom, managing the patients with neoadjuvant chemotherapy and according to response to two groups, the one with breast conserving surgery and the other one with mastectomy. So I think we're going to get some evidence that even inflammatory breast cancer, if it gets a good response from the neoadjuvant chemotherapy, most likely can be managed nowadays with more conservative surgery. And I think we can move on, Michalis, to the next case.
Okay.
I think that was a warm-up case for everybody. I hope you are already warm up for the next one and for more challenging questions. Michalis.
Yes, thank you, Sophocles. It was a warm-up case. I wanted, to take the microphone and, share my opinion with you. I absolutely agree that we could go on discussing on this case for hours. But let's move on to the second one. So I would like to call Mr. Zachariadakis, who is a consultant breast surgeon from the UK. And Kostas will share with us a case with an ER positive HER2 negative breast cancer, and we'll have to debate whether doing less surgery gives us less information about the status of the patient and how this affects the idea or the knowledge we have on her extent of the disease and the consequently her treatment. Kostas. Kostas, we cannot hear you.
Should turn on your
Yeah,
microphone.
yeah. Sorry, I was muted. So thanks, Michalis. I would first like to thank you for the invitation, and I would like to express my gratitude to the Hellenic Society of Breast Surgeons that have demonstrated a continuous commitment to advancing evidence-based surgical knowledge, and I'm grateful to be part of this effort. Okay, there we go. No conflict of interest. So we have a 67-year-old female patient was referred to our symptomatic service complaining of a left breast lump. Onset of her symptoms was 7 weeks ago. She feels the lesion has slightly increased in size and is tender on palpation. She denies any nipple discharge, nipple changes, or skin changes. 25 years ago, she had a benign lump removed from her left breast. You have her family history, no family history, and the drug history and allergies. So on examination, there was a 3-centimeter palpable mass located in the left upper inner quadrant at around the 11 o'clock position with suspicious clinical characteristics, P5. There was no skin tethering, nipple inversion, or nipple discharge noted. Clinical examination of the axilla was normal. So on mammography in the upper medial aspect of the left breast, there was a 35 millimeter spiculate asymmetrical density. Appearances were suspicious for malignancy, no further focal abnormality in the other breast. Moving on to ultrasound, in the area of concern, there was an irregular hypoechoic mass measuring 31 by 21 by 18. Appearances were those of a malignancy, no further suspicious abnormality in the rest of the breast. In the left axilla, there were 4 to 5 lymph nodes that appeared to have slightly increased cortical thickness. This was a 3. So the patient underwent ultrasound-guided needle core biopsy of the left breast mass and ultrasound-guided FNA of the left axillary lymph nodes. Pathology revealed the presence of an invasive ductal carcinoma, NST, non-special type, grade 2, ER/PR strongly positive, HER2 2+ on immunohistochemistry, negative on DDIS, T67 was low, and the FNA of the axilla was negative LC2. So this is stage CT2, C and not. So what is the next step? Would you perform mastectomy plus minus immediate reconstruction and sentinel lymph node biopsy, wide local excision and sentinel lymph node biopsy? Would you offer the patient neoadjuvant endocrine therapy followed by surgery, or neoadjuvant chemotherapy followed by surgery?
Thank you, Kostas. Let's vote now. Would you treat her with upfront surgery, mastectomy or wide local excision, or you would give neoadjuvant treatment a chance? Is it a chemosensitive tumor? The poll is up now. Please vote. We have 15 seconds. This is not the most chemosensitive cancer. And I'm not sure that the wide local excision is feasible. It's a big tumor for that breast. Okay, so voting is up. Can you see the results, please? I'm being provocative. So most of us voted what I voted, wide local excision and sentinel node biopsy. If Mr. Exarchos is with us, Yorgos, could you share your opinion with us?
Yes, of course. So I voted for one. We know that they are positive HER2 negative cancers are not sensitive to neoadjuvant chemotherapy. So we're confident with this decision. And she needs to be at least 6 months on endocrine to see some response. Now, taking into consideration the tumor size and the breast size, I'll be very reluctant to do breast conservative surgery. However, I would like to see her clinically how she looks like, to see the degree of ptosis. But having had a look in the mammogram, I think it's unlikely it will be very challenging to conserve the breast with clear margins.
Thank you, Yorgos. This opinion is important, very interesting, especially if you consider that it is coming from Mr. Exarchos, who has a significant experience in perforator flaps. I would like also to hear a Medonc opinion. Karima, do you have an opinion on this?
Yeah, well, as I saw, it was classified as CT2N0. And it's a luminal disease, not really highly proliferative. I mean, we don't have a high Ki-67 to justify any need for the new adjuvant chemotherapy. So we are not sure it will be very chemosensitive. So I would also be more for upfront surgery, and based on the pathology report after the surgery, because it's N0 T2, I mean, then we will see if there is any other prognostic factor that will push us to go for chemotherapy or any intensified treatment with endocrine therapy plus anti-CDK4/6, for example. So we will see the results after a report, but I'm for upfront surgery.
Ms. Urvasi?
Yeah, I'd like to comment on the fact that I understand the reasoning behind upfront surgery, given the molecular classification of the tumor. And we know that it's usually the luminal B if we were to really think of neoadjuvant qualify for that. But given that this is a clinical decision, I believe that it's something that could be discussed with the patient in clinic, and it's a clinical decision whether or not breast conservation would be feasible. So I would leave it to that. But there are some ongoing trials currently in the UK that are looking at neoadjuvant endocrine treatment in these patients as an option, and Ki-67 being a marker at different time points that's looking at response to neoadjuvant endocrine treatment and whether or not, these patients would respond to neoadjuvant endocrine in order to de-escalate for breast conservation.
Oh, thank you. We have a question from from Thorsten Kuhn. And the question is, what about genomic profiling? Because optional endocrine induction to decide on chemosensitivity.
Yeah, hi, Michalis. I may explain this further.
Yeah.
Can you hear me?
Yes, we can.
So because I don't know if it's really very well known internationally, but we have the ADEPT trial. And in the ADEPT trial, patients with the Oncotype DX score less than 26 received a short endocrine induction treatment of 2 to 4 weeks. And when the Ki-67 fell below 10%, so they were they had a very good outcome if treated exclusively by endocrine treatment. So this might be an option to go for a very short, we call it endocrine induction, to decide on chemosensitivity or not. If she was not chemosensitive, we would go probably for primary surgery as well with oncoplastic concept. Otherwise, we would treat her with chemotherapy. So this would be one suggestion.
Thank you, Thorsten. This was in our minds, but in many countries, including Greece, we cannot do oncotype on core biopsies.
Okay.
We can only do it on surgical specimens. Thank you. But let's move on. Kostas, do you want to go on, please?
Yeah, so I was just thinking, I'll skip a slide and go back to it because it will make more sense. So I'll go ahead and tell you what we actually did. We did a left-wide local excision and sentinel lymph node biopsy. So we are recruiting patients. We do run a trial for neoadjuvant endocrine therapies, the ENDONET trial. She didn't want to be recruited in the trial. We did offer her the option of mastectomy versus breast conserving surgery. I would have preferred to do a mastectomy. She wanted to preserve her breast, and in any case, we went ahead and did a left-wide local excision and sentinel lymph node biopsy. So this showed a grade 2 IDC 44 millimeters, no in situ component present, lymphovascular invasion was present, all margins were negative. Again, strongly positive, PR positive, low Ki-67 HER2 negative, so P2, PT2 and 1. I'm going back to the previous slide, which is a question, an additional question. Would you perform frozen section on the sentinel lymph node? So if we can vote.
So we're in the operating theater, we remove the tumor, and we decide whether we do a frozen section or not, and what's the meaning behind it. I guess that this is not a decision taken on the spot. It's sometimes a policy of the unit. Let me vote. So time is up. Can we see the results, please? Frozen section or not frozen section? Okay. So
that's perfect. That's the perfect poll.
Perfect. That's perfect. That's perfect. I'd like to call Vasilis Venizelos if he's here with us. I know you're smiling, Vasilis, and I selected you on purpose. So can you share with us your opinion? What would you do?
Thank you, Michalis. Although our policy in our department is to perform frozen section in sentinel node, for the last couple of days we have the discussion either to abandon the frozen section or not, because we've done a survey in our database and we found that most of the sentinel node biopsies were negative in frozen section when we decided to do the frozen section in clinically negative patients. Therefore, is a big question, and I'm not sure if we have the answer, but it's time consuming, the frozen section. It's about 30 minutes, at least in our department, to take the answer from the pathologist. And I think it's very valuable, the frozen section, when you have 4 lymph nodes removed and you're waiting for the answer if these 4 lymph nodes or 3 of them are negative or not, to proceed to axillary lymph node dissection. In the case that we are going to do wide local excision and cellular node biopsy in negative axilla, I'm not sure if the frozen section is very helpful. It's very helpful when the patient she had the neoadjuvant chemotherapy. This is very helpful to us because we can offer one operation in the patient if the cellular node is positive. But I'm not sure, and although I've done all these frozen sections in all my patients with cellular node biopsy, the last couple of months I have to be honest, I'm start thinking that it's not going to be necessary.
Thank you, Vasilis. I wonder how one positive node on frozen section will change the course of the procedure. Thorsten, are you there?
Yes, Michaelis, I am there.
Can you share your opinion with us? Would you do a frozen section? I would think I would need 3 positive nodes in frozen section to make me decide that she needs a clearance.
Absolutely, I agree entirely. So we would not go for frozen section because there would not be any surgical implications, except that you had 3 positive lymph nodes, which certainly is very rare.
Thank you. Let's move on, Kostas.
Thanks.
In addition, may I still add this, because on frozen section you still have some loss of material, some loss of tissue because of the technique. So we rather prefer to have have the lymph node completely embedded and have a better information on the final histologic result.
Absolutely. So you lose some of the valuable lymph node tissue. So Kostas, can we move on, please?
Yes, just to say, yeah, in the NHS, it's extremely difficult. I would say probably impossible to do frozen section, so we didn't go do any frozen section. So let's move. So just to remind you, grade 2, 44 millimeters with yeah. So with 2 positive nodes. So what is the next step? Along with whole breast irradiation, endocrine therapy for 10 years, bisphosphonates, would you do a completion axillary lymph node clearance? Would you offer the patient axillary radiotherapy as part of like the Amaros trial? No further surgery at this stage, Oncotype DX to assess benefit from adjuvant chemo. No further surgery, adjuvant chemotherapy. No further surgery, adjuvant chemotherapy and abemaciclib for 2 years. No further surgery, adjuvant chemotherapy and ribociclib for 3 years.
Kostas, because I lost you at some point, can you show us again before voting? Can you show us again the result of the nodes?
Yep.
The biopsy, because
it's 2 out of 2 with macrometastases.
Macro.
Yep.
So we have 2 out of 2 macrometa. Was it a frozen section?
No. We don't do frozen section. No.
Okay, so histopathology, routine histopathology, 2 out of 2. Okay, let's vote now. Can we? Yeah. And was it lobular cancer?
No, it was invasive ductal cancer.
Ductal, okay. It's tricky. This is a tricky one. I don't know what to vote.
Just reminds us, how old is she?
67.
67.
Okay, I think we've had enough time. Let's see the result, please. I see. So most of us, and we're primarily surgeons, I guess, voted for completion axillary node clearance because I guess we are afraid that we're missing some information there, that there are nodes, positive nodes hiding in there that we would like to take the information, to have the information. Prof. Markopoulos, if you're with us,
Yes, I am.
what is your opinion on this?
Well, first, I agree that it's a very, very interesting question because you could support most of the options. However, I feel that completion of axillary lymph node surgery is the proper choice in this case. And the reason is that we have a large tumor, 4.4 centimeters, grade 2. Clinically, she's a high-risk patient. And only knowing about 2 positive nodes, our decision could be misleaded. And by this, I mean, for example, there is an option of Oncotype DX, for example, which if it comes low, then we could go for hormonal therapy with the 2 positive nodes. However, with more nodes, this would mean chemotherapy. And certainly, this is very interesting case because we also have a dilemma nowadays. From one point, the escalation of surgery, which might lead to less knowledge of data, which could lead us towards chemotherapy and adding factors like ABEMA. So I would certainly go for more lymph nodes in the axilla. And I take the opportunity to say that this is the cases where I certainly do frozen section of the lymph nodes, because in cases like this, I could do it straightforward in theater, no matter if I waste half an hour, as Vasily said, which I agree. So in conclusion, I would certainly vote for number 1, which I did.
Thank you, Prof. Yes, I agree. It makes you think whether frozen section is sometimes, useful. Before moving to the 2 surgeons, Mr. Kontoulis and Ms. Urvasi, I would like to ask Prof. Markopoulos, would you agree with the tendency we have in Greece of removing a few more nodes, although this is not written anywhere, not only 2 sentinel nodes, removing the surrounding tissue perhaps, in order to gain more information on the nodal status?
Well, my answer wouldn't be if I agree or not. My answer will be yes, because I'll do it. No evidence for that, but I do it. I'm not trying just to encapsulate and find only the sentinel lymph node to remove it. And a few times I had surprises. So if you want me to say that I agree, I would say yes.
Thank you. Dr. Kontoulis?
Yes, I will go for a completion axillary node clearance, and then I would have done a frozen section because things were not ideal from the beginning. We have an abnormal axillary ultrasound scan, a C2 cytology, and then 2 out of 2 lymph nodes that are positive. And we know that the ultrasound scan that shows abnormal lymph nodes in 60% shows that it has more than 3 lymph nodes that are positive. We also know that the many predictors of non-sentinel nodes that are positive take into account the ratio of positive sentinel nodes. So for me, there are more lymph nodes that are positive in her axilla. So I would go for a completion axillary node clearance.
Thank you. If Dimitris Trifonopoulos is with us, I'd like
Yes,
to
I
hear
am.
medical oncologist's opinion.
Well, it hurts to admit, but I think that she needs a completion axillary lymph node dissection for two reasons. I need to know if she has N1 disease, in which case getting a molecular signature test might spare her from adjuvant chemotherapy altogether. If she has N2 disease, then she should get chemotherapy, and she is a very good candidate for adjuvant abemaciclib. And without knowing that, she cannot get this medication. So yes, I think that I voted for axillary node dissection. Yes.
Thank you, Dimitris. I see a lot of raised hands. I'm sorry, we have to move on. So Kostas, can you please go on?
Yeah, I'll move on just to make a short comment. Nobody commented on axillary radiotherapy as part of the Amaros trial,
Yes,
which would be an alternative
Dr.
option.
Maragoudakis raised his hand, but if you want to move on, I will ask him later.
Yeah, okay.
I will have that.
All right. So what we did, the patient fit the Z11 criteria, so potentially we could have avoided doing a clearance. Now we used two separate nomograms to predict the possibility of 4 or more positive lymph nodes in patients with 1 to 3 positive nodes. So now the presence of more than 3 nodes would affect further adjuvant treatment, as the patient would be eligible for adjuvant abemaciclib. She wasn't with the information we had at that point, and adjuvant radiotherapy to regional lymph nodes, supraclavicular fossa, internal mammary chain. The first nomogram that you see here uses tumor location, T-stage, extracapsular presence of disease, number of positive nodes, and number of negative nodes in the sentinel lymph node biopsy to predict the risk of having more than 3 nodes, and estimated the risk between 45 and 50. So that was the risk of having at least 4 nodes. And this is another nomogram, uses more or less the same factors, but also includes lobular histology and the presence of lymphovascular invasion, estimated as a similar risk between 45 and 50%. So we did proceed with the left axillary lymph node clearance. Final histology from the clearance showed 2 out of 18 nodes with macrometastases. The total nodal count was now 4 out of 20 with macrometastases. Extracapsular spread was not present, so stage PT2 and not. So what is the next step? Whole breast irradiation with endocrine therapy, bisphosphonates, plus adjuvant chemotherapy with abemaciclib, adjuvant chemotherapy with regional radiotherapy and abemaciclib for 2 years, or adjuvant chemotherapy with regional radiotherapy and ribociclib for 3 years.
Thank you. Let's have 15 seconds to vote. I would like to hear oncologist's opinion and radiotherapy doctor opinion, I think. Okay, we've had enough time. Let's see the results. So most of us opted for answer 3, adjuvant chemo with radiotherapy and abemaciclib. I guess abemaciclib is not given in all countries under the same regulations. Let's hear a medical oncologist. Could you, Karima, are you there?
Yeah,
You're there. Can we have your opinion? What did you vote for?
Yeah, I voted for the third option of adjuvant chemo, for sure, also with radiotherapy and adding abemaciclib. And we have seen now that thanks to this lymph node dissection, so we have restaged our patients. So there was like an upstaging of the disease. Well, so especially for the chemotherapy because first she was N1 for her age. If we stayed at N1, so normally we should go for genomic signature to see if she is fit or eligible for chemotherapy or not based on the recurrence score. But now with N2, there is more, supportive data that she needs chemotherapy. That's first of all for chemo. So this lymph node dissection really upgraded, upstaged the stage of disease. Meantime, for the adjuvant anti-CDK4/6, well, for the T2 N1, as she was classified at the beginning, she was already eligible for ribociclib because, for ribociclib, it included patients at earlier stages, so they can be T2 N1 and be already eligible for ribociclib. But for abemaciclib, now with moving to N2 disease, she is officially candidate to abemaciclib, and we know that we have more mature data and more follow-up confirming the benefit of abemaciclib for the setting. So I will go for adjuvant chemo, radiotherapy, and abemaciclib.
Before asking Dr. Dimopoulos, I would go to Dr. Maragoudakis if he's with us, because he had raised his hand.
Okay, yes, I'm with you.
Okay,
Now I think it is out of what we're talking about. I would like to comment on the need of a frozen section. Though I know that we lose time and there is a possibility of false negative answer, or that we don't treat with the best way the tissue we have, in case we had performed frozen section and it was positive, then we would perform axillary lymph node dissection at the same time, so that we'd avoid an extra operation, as we comment after that, and we would have a more accurate decision in case we have more positive lymph nodes at the specimen of the axillary lymph node dissection.
Okay. Dr. Dimopoulos, do you agree that the clearance changed your treatment plan, the radiotherapy treatment plan, or it's more or less the same?
Well, I think when going back to the previous question, I think that the patient could have been treated initially with radiotherapy, but we had these initial findings in ultrasound. And so surprisingly, or not surprisingly, because of the initial findings, at the end, we had 4 positive lymph nodes, and we have now a dissected axilla, which means that we will spare the part which is dissected, but we will treat the supra and infraclavicular region, and of course the breast. But here I would focus more on the technique of radiotherapy, which has to be given. And this because this is a young patient with a left-sided breast cancer. And this means that we should use some techniques to protect the heart. And this is, of course, respiratory management techniques. And in that case, we could use, for example, deep inspiration breath-hold techniques, and so to protect the heart.
Would you include the internal mammary nodes in the field, because it is a 44 millimeter tumor in the center of the breast?
Yeah, this is, of course, you know that to treat the internal mammary nodes is always an individualized treatment decision. But this is a case where we could do something like this because of the size of the tumor and because of the number of the positive lymph nodes.
Okay, so Kostas, should we move on?
Yep. So the patient was referred for adjuvant chemotherapy, whole breast and regional node radiotherapy, endocrine therapy 10 years, bisphosphonates, abemaciclib for 2 years. He now fits the criteria. So the main question for discussion in a case like this is regarding escalation or de-escalation of treatment. We could have stopped during the sentinel lymph node biopsy. I'm a bit surprised that not a lot of people went for Z11 criteria. She fits the Z11 criteria for omitting axillary lymph node clearance. She also fits the criteria for performing Oncotype DX in postmenopausal women with up to 3 nodes. From the sentinel node, she had 2 positive nodes. She would not fit the monarchy criteria for adjuvant abemaciclib if we had stopped at the sentinel lymph node biopsy. But she, although there is, we don't have final results from the NATALY trial for ribociclib, these patients that are stage 2, she was stage 2 following the sentinel lymph node biopsy, she would have fit that criteria. So proceeding with axillary lymph node clearance and identifying 4 nodes with macrometastases, now we're escalating the patient's surgical and adjuvant treatment. And she will have, according to PREDICT, she has an 8% additional benefit from adjuvant chemotherapy in this case. So I just have here, just briefly to help the discussion, the criteria, eligibility criteria for these trials, the Z11 Monarchy, NATALY, and the RX-Ponder trial, and to help articulate the clinical dilemmas. So there is a group of ER-positive, HER2-negative patients that are positive on sentinel node that fit the Z11 criteria and the RX-Ponder criteria for performing Oncotype DX, but don't fit the Monarchy criteria. Therefore, they would not be eligible for abemaciclib unless we proceed with the clearance. Obviously, we will do clearances in some of these patients, and they'll have an unnecessary procedure. The clearance will come back as negative. So this is, I believe, the dilemma. So, axillary clearance, and I think now most of the panel members agreed to that. I was thinking that more people would go for the Z11. So the clearance does not just affect our decision for abemaciclib. So, and let's consider 2 extreme scenarios for this patient. In scenario A, let's say we stop at the sentinel lymph node biopsy. We did an Oncotype DX and it was negative. She wouldn't have any chemo. She wouldn't have abemaciclib and probably wouldn't have radiotherapy to the supraclavicular lymph nodes. Whereas in this case, we escalated and she now had chemo, abemaciclib, and regional node irradiation. So just to finalize the presentation and the discussion, do you believe we should perform further axillary surgery in a subgroup of patients with ER-positive, HER2-negative breast cancer that fulfill the Z11 criteria? Answer 1 is yes. The information from the axillary lymph nodes can guide further management and adjuvant treatment, or answer 2 is no. There will be no significant benefit from this practice, but it will increase complication rate.
So, Kostas, you're saying if there are exceptions to Z11, basically.
So, yeah, that's the initial question, and then we can discuss what would you consider an exception if you think there are exceptions, yeah.
Sorry to interrupt, but I think the point here is whether we should escalate our axillary surgery based on the data that we need to obtain. So are we doing more surgery to get more data, or are we happy with what we're doing? I think this is a question here, isn't it? And that was a question in the European Breast Cancer Conference. There was a debate about that. So it's not about this case, it's about every single case
in general
that fulfills this criteria. You have 2 out of 2 lymph nodes and you have an ER-positive, HER2-negative breast cancer. What are you doing? Are you doing more surgery, or are you stick there and are you happy with it as you have been doing all these years?
Let's bring up the voting box. All the results, have we voted?
Yep.
Yes. Okay, we're again divided here.
Good.
That's good. That's all.
Because it's not clear. There's no clear answer, but yeah.
Ms. Urvasi, what did you vote? Are you with us?
Yes. So
What's your opinion?
I actually voted saying no, because I feel that while we are trying to de-escalate on one hand, this is, a step towards escalation, and we need to understand all patient factors while we are trying to plan this. For example, in the lady that we discussed previously, I wanted to ask how her overall fitness is to get all those systemic treatments that have been advised. While we are trying to get more information in order to plan or escalate systemic treatments, we also need to bear in mind the toxicity from these treatments. And while we have 2 positive trials for the CDK4/6 inhibitors, there are also so I'm trying to be a devil's advocate here and saying that we need to balance what we are trying to do.
Thank you. Let's move on, I think, because we don't have time. We have a couple of minutes. Kostas, do you want to give-
Michalis, just a very quick comment, may I?
I think Mr.
Yes.
Masco, yes, yes.
I agree, but we have to consider something which in my mind is very important. This patient is a high clinical risk patient based on her tumor site and grade. And if we see both trials, Z011 and our responder, this group of patients is very, very small. And this is another thing we must have in mind. We can't go in general for the criteria of Z11 or our responder. For example, a lot of times I'm saying, do we follow Z11 criteria for lobular carcinomas, which are less than 8% of the population? So I think we have to personalize our decisions, even when we have data for such important trials. And this is the reason why I voted for axillary lymph node dissection in a case like this. It would be completely different if we had a patient with 1.5 centimeter tumor and 2 positive lymph nodes. Thank you.
So there are exceptions. Thank you. Kostas, can we move on, please?
This was the last. So
1
I mean,
minute.
this was
We
the
have
last
1 minute.
slide. So I don't know
Okay,
if
then.
anybody else wants to
Another
make
minute.
any other.
Anybody else with a burning comment?
Yeah, just before I start talking about the next case, I think most people believe in AMOROS and believe in Z11. I think in these studies there were people with 2 out of 2 lymph nodes. That's why we got this case on, because if you say you believe in Z11, you need to follow Z11, and this fulfills the criteria of Z11. So either you follow it or not. This is my point.
Yes.
That was provocative. I know that was provocative because finally,
but-
eventually, we showed that some people have more lymph nodes, but we know that. I mean, from Z11, we know that there were people in the lymph node dissection that had 4 and 5 lymph nodes. We know that, and they did well. After all these years of follow-up, they did well. So I don't know whether this escalation of systemic treatment is so necessary. Just for the history, in the EBCC, the voting was in favor of not further surgery, because they showed some data that we have to clear about 100 axilla just to get 1 patient with benefit out of all
It
these
is,
cases.
it is 128
Exactly.
clearances.
Exactly.
I'm not sure that if I'm allowed to reveal so it's 28 clearances
For 1 benefit in local
for 1
recurrence
benefit
rate.
in 5 years.
And in local recurrence rate, not in overall
No,
survival.
this is free. This
This
is
is
free.
free. Okay, we're happy
Not
we
sure
got
that
this
it's
discussion, but we
about
have to carry on because we are already 1 minute behind.
Okay.
And we
okay.
don't want 1 minute behind.
Uh,
So we carry on with the next case. We're gonna
Kostas,
call
thank you
on
very
stage,
much. Kostas.
Thank you. Thanks.
Thank you,
Thanks.
Kostas. very much.
I'll mute my.
Mr. Exarchos, George Exarchos is going to talk about another provocative issue. How do we manage multicentric and multifocal breast cancer? So, George, carry on. The stage is yours.
You're on mute. Can you hear me?
Yes, we can, Yorgos.
Yes. So first of all, thank you for the Hellenic Society of Breast Science for the invitation, and also today I would like to express my gratitude also to Mr. Peter Barry, who's a colleague. I had the privilege to work with him and during my fellowship at the Marsden. He was an excellent tutor and mentor. So the case I'm going to present today, it is a 42-year-old lady who presented in the symptomatic clinic with a palpable lesion in the upper breast. She has a background of irritable bowel syndrome and she takes Buscopan. Her performance score is 0. With regards to her family history, her mother was diagnosed with breast cancer, which was estrogen positive, HER2 negative, and she was treated with surgery and adjuvant chemotherapy. In addition, her paternal auntie had breast cancer in her 60s. Now, on examination, she has a double D cup size. There was a 3 centimeter palpable mass in the upper outer quadrant, which was a malignant mass, P5. The overlying skin was normal, there was no changes, there was no nipple discharge, and the ipsilateral lymph node examination showed no palpable lymph nodes. So she was at T2, N node, M node. With regards to some oncoplastic measurements, the suprasternal nodes to nipple was 229 millimeters bilaterally. Nipple to IMF was 16 centimeters, and she had a parenchymal ptosis of 7 centimeters. So with the triple assessment with the mammogram, which showed a 17 millimeter distortion in the upper outer quadrant, and we call this lesion 1. This was associated with diffuse macrocalcifications extending from the medial to lateral area, approximately 5 centimeters. This is superior to the lesion 1. In addition, as you can see on the lower breast, there are some benign lesions consistent with cysts. Now, she had also an ultrasound scan of the left breast, which showed that the malignant lesion was a 15 millimeter mass with ill-defined margins, and it was scored as U5, consistent with a malignant lesion. And an ultrasound scan of the ipsilateral axilla showed the solitary lymph node with thickened cortex and displacement of the fatty hilum. It was scored as A4. So this is the first part of our question now. So what we do with regards to the next step? Would you biopsy under ultrasound guidance the visible lesion on the lymph node? Would you do an MRI scan before any biopsies? Would you do a single stereotactic biopsy of the macrocalcifications and the lymph node? Or would you biopsy both areas of macrocalcifications, medial and lateral, to prove extent, ultrasound guidance of the index lesion, and biopsy of the lymph node?
Thank you, Giorgos. So we have a dilemma on what to biopsy, or whether we should move to MRI before doing anything else. Could we vote, please? Yes, there it is. In my mind, it's quite straightforward, but should we see the results now? So most of us decided on MRI. Mr. Koudoulis, what did you vote for, Thodore?
I voted number 2, MRI first, and then after MRI, taking into account the results, if there is no surprise, I will do number 4.
Thank you. Should we move on, please?
Yes, so we did not do an MRI scan first. We just go straight for biopsies. So we did an ultrasound guided biopsy of the lesion, index lesion of the left breast and the axilla. And we put a clip as well, a thread clip in both areas. So both the index lesion and the lymph node were clipped. In addition, we did stereo biopsies of the 2 ends of the macrocalcifications. And also we clipped these biopsies as well. Now, this is what the post-biopsy mammogram showed, looks like. There's a small hematoma in the upper outer and upper inner quadrants following the stereo biopsies. So lesion 1 is the index lesion that we biopsied under ultrasound guidance, and lesion 2 and 3 are the stereo biopsies in the upper outer and upper inner quadrants. These are the results of the pathology. So the index lesion was a 26 millimeter grade 2 invasive duct carcinoma, no LVI. It was ER7 PR8 HER2 negative. And the other two lesions over the medial and lateral part of the microcalcifications had similar pathology. So grade 1 invasive duct carcinoma, estrogen positive, HER2 negative. And axillary lymph node biopsy showed metastatic disease. Now, we staged the patient with a CT chest, abdomen, and pelvis, and a bone scan which was negative. Now, taking into consideration the young of her age and the family history, we want to do a genetic testing for this patient. Usually in the NHS takes around 6 to 8 weeks. So we started bridging treatment with letrozole, and she had a 2-monthly dose of ovarian suppression. So this is how she looks in the clinic. We mark the area of the palpable lesion end of the biopsies. So lesion 1 is the index lesion that we did the ultrasound guidance biopsy. Lesion 2 and 3 are the biopsies that we did under stereotactic guidance, grade 1 invasive duct carcinoma, and this is the lymph node that was involved. It was positive. And now this is our next question. What would be the management about the MRI scan? Would you do an MRI scan to decide the extent of surgery, mastectomy versus conservation? Do you think an MRI scan is not necessary since the patient is a mastectomy, as it is multifocal, multicentric disease? Would you do an MRI scan to evaluate the other breast, or do you feel that there is no benefit from an MRI?
So basically the question is here, can we put up the poll box? Thank you. The question is here, is it MRI to see what we should do, or because it's an extended area in the breast, MRI is not necessary because we move straight to mastectomy. So let's vote. We have 15 seconds. Okay, let's see the results now. I see. So again, we have choice 1 and choice 3 competing for the first place. MRIs, the first one is MRI to see the extent of surgery. So to map out the breast to see what we need to remove and what not. And 3, the answer 3 is that we're not concerned about this breast because we have decided about it. It's the other breast we're concerned about. Right. So could I ask from Mr. Zachariadakis for his opinion? Kostas, are you there?
Sorry, yeah, I'm just unmuted myself. So, okay. Okay, I'll tell you what I said. My answer was MRI to decide extent of surgery, mastectomy versus breast conserving. Now, to be honest, this case I would have done, it's too multicentric. It's, I think, technically very difficult procedure to do breast conserving surgery. So I think an option would have been, mastectomy, and that's it. But if you are to consider breast conserving surgery, there is evidence that in multicentric disease that performing an MRI prior to surgery decreases the risk of positive margins and local regional recurrence. I think it's the ACOSOC Z 11102 trial that showed that MRI in cases like that does improve surgical outcomes. So if you are to do for multicentric disease, considering breast conserving surgery, I would definitely do an MRI.
Is there a limit of focus, of number of foci above which we cannot consider breast conserving surgery? Prof. Markopoulos, do you have any answer, any insight?
Well, actually, I agree with Mr. Zachariadakis. Performing an MRI in this case has to do what you have in mind. if you have taken your decision about mastectomy due to multicentricity, because this is a multicentric tumor, multifocal and multicentric, which is more important, then MRI would be of no help apart from the contralateral breast. So a combination of 1 to 3 should be also an option. As for the number of foci, I really don't mind as long as are in same quadrant, no matter if they are 7 or 12 or 4. What it worries me is that it is multicentric disease, and most of all, see the patient is only 42 years old. This is also something very important, which could affect my decision towards a mastectomy or an attempt for breast conservation. To be honest, at this moment, so far, I would think preferable for this young lady mastectomy reconstruction instead of trying to preserve this breast with multicentric tumor.
Okay, thank you, Prof. There's a lot we can say about this, but we need to push on. So could we move on, please?
So we would incline towards for a breast conservative surgery with an MRI scan. So this is an MRI scan from superior to inferior, which shows some additional findings. So this is a deliberately slow scan, so you can see the extra findings. So it showed extensive non-mass enhancement between the lesion 2 and 3, and also posteriorly and superiorly to lesion 1. I will, so we can see here on the left side, where it says lesion 4 is non-mass enhancement posterior to lesion 1. I will try to make it a bit more easy to understand with some static pictures. So lesion 1 is the index lesion that we took the biopsies, the grade 2 invasive duct carcinoma, the upper outer quadrant, measuring 17 millimeters. You can see here also the signal void. Now you can see on the picture on the right side of your screen, the lesion 2 and 3. These are the microcalcifications, the biopsy we took from microcalcifications. You can see the hematomas that are formed, and also extensive non-mass enhancement between these two areas. The non-mass enhancement usually it spans an area of 70 millimeters anteroposteriorly, 42 mediolaterally, and 23 craniocaudally. Now, lesion 4 is an area of non-mass enhancement posterior and superior to the index lesion. And also the MRI scan showed in the upper central breast at 12 o'clock position, a 9 millimeter nodule. So we discussed this case in RMDT. The patient was very adamant she wants breast conservative surgery, and we agreed that if we consider breast conservation, we should do some additional workup and biopsy additional findings. So this is an illustration so far, because it can be challenging to understand all this multifocal disease. So it's the left breast. 1 is the index lesion, grade 2 invasive duct carcinoma. 2 and 3 are the median and lateral areas of macrocalcifications, grade 1 invasive ductal. 4 is posterior and superior to the index lesion, non-mass enhancement. And 5 is the upper central breast, the nodule that we've seen. So we did the second look ultrasound scan and of the non-mass enhancement in the left upper outer quadrant. This showed multiple less than 5 millimeter foci of that area, and we biopsied the most superior and lateral area to prove extent of the disease, and we put a coil in. And this showed a grade 1 invasive ductal carcinoma, ER3, PR8, HER2 negative. And we also did a second look ultrasound scan of the upper central breast, and the 12 o'clock position nodule showed the 9 millimeter U5 lesion, which was biopsied. and actually it showed a B3 lesion with atypia. So this is the post-biopsy mammogram, which I'm trying to summarize everything. So we have now the lesion 1, 2, and 3. Lesion 4 is in the upper outer quadrant, the most superior and lateral grade 1 invasive ductal carcinoma. And lesion 5 is the B3 lesion in the upper central breast. I think the key part here is that all these lesions are located in the upper central breast, and the patient has a WD size and significant ptosis. So the next question would be, what would be the next step? Would you go for surgery? Would you recommend neoadjuvant chemotherapy to downsize the disease and discuss breast conservation, or carry on with neoadjuvant endocrine and ovarian suppression?
Okay, let's vote. Surgery or systemic treatment. So we have a multifocal or multicentric disease. Is neoadjuvant systemic treatment going to change anything? Okay. Let's see the results now. Yeah, which is not a surprise. I mean, nearly all of us voted for surgery first because neoadjuvant treatment will not change anything. Should we move on, please?
Yes. So this is the summary of how all these lesions look in the breast. So we agreed as well to go for primary surgery. Now, the next question is, what type of surgery would you do? Would you do a mastectomy plus minus reconstruction and clearance? Could you do a mastectomy plus minus reconstruction, sending lymph node biopsy as TAD? Could you do a chest-wall perforated flap and send lymph node biopsy or TAD? Or would you do a therapeutic mammoplasty with a sending lymph node biopsy or TAD with contralateral symmetrization?
So let's bring up the voting box. First of all, I just want to focus on two things. First, whether avoiding a mastectomy is oncologically safe, because we have multiple cancers in one breast, covering a large portion of the breast. And second, if we decide to preserve the breast, is there a technique to fill the gap of this? It will be a huge defect if we want to be oncologically radical in the breast. So it's a matter of technique and a matter of oncology. Okay, let's see the results now. Right, that's very interesting. The majority of us voted for a mastectomy reconstruction and some axillary staging, and some of us voted for therapeutic mammoplasty, breast conservation with a mammoplasty with symmetrization. Right.
Vasilis, I think, is about to talk now, isn't it?
Yes, I was about to ask Vasilis if you wanted to say something. Vasilis, we cannot hear you.
Sorry, apologize. I will totally agree with the number 2, mastectomy and reconstruction sentinel node biopsy for many reasons. First of all, although chest wall perforation is a very good operation, in my unit, we don't have experience of chest wall perforator. Secondly, I will do a mastectomy, and after that, I will do reconstruction with DIEP flap. And probably, which is going to give me very good results, I'm going to remove all the breast, and I'm going to have a very good shape. And probably I will do a symmetrization on the other side. But I will be very, very afraid to leave a breast behind. Therefore, I think for my point of view, mastectomy and reconstruction is going to be my preferable choice.
Thank you, Vasilis. Dr. Urvasi, do you have any ideas on this?
I voted for option 4. I don't think it's unreasonable to attempt breast conservation as long as you're able to excise the area of concern, which it seems is all in the upper part of the breast. She has glandular ptosis based on the picture that I saw. So I would attempt to do a breast conservation with therapeutic mammoplasty and symmetrization on the contralateral side. As far as oncological safety is concerned, I think we have some data now to say that it would be safe to attempt conservation in these patients. Although I think it should be a very careful and tailor-made approach. I'm not saying that all patients would qualify. It is a very complex situation, and planning is extremely crucial for us in such situations.
So I agree with you. It's planning and mapping of the breast is very important. Yorgos, could we move on, please?
Yes, I agree with you. I think also it's very important the breast size. But let's move on and we'll do some comments in the end. So we decided to go do breast conservation surgery. So with the WISE pattern therapeutic mammoplasty with the nipple areola complex based on the superior medial pedicle. And the fact that she has double D size with 13 centimeter parenchyma ptosis, this gives us a very good option to use the lower pole of the breast as what we say a septal perforated flap to fill the gap of the upper central breast. We did the sentinel lymph node biopsy and TAD, and we did the contralateral symmetrization. So you can see the marking here of the WISE pattern and all the tumor that involves in the upper central breast and the upper outer quadrant. So I know this is not a plastic course, but I would like to briefly touch the septal perforated flap technique. And before I get into the more details, it would be nice to remind some the anatomy of the vascular anatomy. So Wernke, a few years ago, she published a paper about the Wernke septum, which is a fibrous septum, which provides blood supply to the nipple. Usually, it is actually the mesentery of the breast, and carries the 4th and 5th intercostal perforator and towards the nipple. Last year, Rancati published a paper. It was a prospective, a cadaveric study, which showed that actually the 5th intercostal perforator does not go through the Wernke septum, but through the lower pole of the breast and towards the medial pillar, like a mammoth tooth. Why do we need to know that? Because in a very ptotic breast, we can do a wedge incision, go down to the breast and use all the lower pole as a septal perforator, and it takes blood supply from the 4th and 5th intercostal arteries. So this is the MRI.
Sorry to interrupt you, because we only have 6 minutes.
Yes,
this is not, it is very interesting. I cannot do that. But
so yes, so this is the MRI scan which shows the 4th intercostal perforator. And this is the technique we use. So WISE pattern technique. We did a wide local excision. The neck was on the superior medial pedicle. We use this secondary pedicle, but what we've done, we use the Doppler. We found the septal perforators. What is the benefit of the Doppler? You can incise the dermis, or even you can incise the breast parenchyma, and this gives you a lot of flexibility to mobilize the breast tissue, the septal perforator in the upper outer quadrant or even in the upper inner quadrant. So this is what we've done. This is the mapping of this patient. So we use the Doppler to find the superior medial pedicle. This is the superior, this is the medial. The other benefit of the Doppler gives you, tell you exactly where is the perforator. It is within the 2 centimeters from the skin. And so you can do some back cutting and release the neck and avoid any tension during the inset to the new position. So this was our specimen after the operation, the white local with the numbers. It was a grade 1 multifocal invasive ductal carcinoma ranging from 1 millimeter to 24. The total area of involvement with invasive disease was 54 millimeters. ER6, PR6 HER2 this negative. All margins were clear, and the node who was involved with the Maxid TAD showed a 5 millimeter deposit, and we use OSNA at the margin, and the two lymph nodes were negative, and the right breast duct was benign. So taking in consideration now that this was a T3N1, what would be the most appropriate next step? Decision on chemo-based chemotherapy based on genetic molecular signatures, ovarian suppression, and endocrine treatment. Chemotherapy without genetic signature, ovarian suppression, and endocrine treatment. Decision on chemo based on genetic signature, ovarian suppression, endocrine treatment, and abemaciclib, or chemotherapy without the genetic signature, ovarian suppression, endocrine treatment, and abemaciclib.
Okay, let's vote now. I will be very interested to hear to the Medoncs opinion on this.
What was the grade of the tumor? Was it grade 3?
Grade 1.
Grade 1.
Grade
Okay.
1.
It's a tricky one, so let's take 5 more seconds. Okay, let's see the results. Okay, so choice 1 was the most popular one. Dr. Trifonopoulos, are you with us?
Okay, from our point of view, it's probably the less popular one. So to start with, I would just like to make a short comment on the short neoadjuvant endocrine treatment, the bridging treatment, especially in a premenopausal lady, giving for a 1 month interval, an AI and an LHRH analog, it will not work. It doesn't have time to work. So I wouldn't choose that. Okay. Now, in terms of her adjuvant treatment, we've got a premenopausal lady with a node-positive disease. So she will be needing chemotherapy. We don't have data on age and menopausal status do count. All the molecular signature tests are not strong enough in young ladies and premenopausal ladies. So I would give her chemotherapy without a molecular signature. And having a nodal disease, I would also offer an aromatase inhibitor with ovarian suppression instead of tamoxifen. And she fulfills the criteria of the Monarch study. Although she has N1 disease, she had a tumor over 5 centimeters. So she would benefit from abemaciclib. So for me, option 4 would be the optimal.
Wow, I'm impressed. I'd like to hear one more opinion from an oncology. Karim, are you with us?
No, she had to go to another meeting. But I think Zachariadakis and Kondoulis, they have both raised their hands to give their opinion. So maybe Theodoris, yes.
I just have 2 questions to Mr. Exarchos. First of all, do we take into account the index mass for the staging, or all the masses to take into account the T? Because the index mass is 24 millimeters.
Yes,
it's not a T3 lesion. What we have, it's multifocal, but it depends on what we take into account, the largest mass or all the masses. And the second question that I have is, do you, in your unit, do you routinely do TAD even though you're not doing neoadjuvant chemotherapy?
Yeah.
Because preoperatively you had a suspicious lymph node, you took a needle biopsy and it was positive. Do you routinely do a TAD in all these cases?
Thank you for the questions. So with regards to the question number one, I spoke with a pathologist because I had the same question. He told me that the total area of involvement with invasion was 54 millimeters. So it was a continuous disease with invasive cancer, but there were multiple areas, that he could see in the microscope in the microscope, varying from 1 millimeter to 24, but it was continuously invasive disease, measuring 54. So he graded as T3.
Okay.
And with regards to your second question, so when I was working in the Royal Marsden last week, I have joined the new unit this week at Kingston. So we routinely perform primary TAD in patients who fall in the Z11 criteria. So T1, T2 with one usually node. So this was the standard practice. And we have published this data. I can send you the information if you need. And we managed to avoid the axillary node clearance in up to 70% of the patients.
So it's
So,
primary TAD. So we mark the node which looks abnormal on the ultrasound scan.
Yes, so what we do, let's say this was T2 and 1, we mark the node with a clip, then we put a MAC seed, and on the same day we do the wide local TAD, Sentinel, and OSNA. So we send we know straight away with the result. If it is up to 2, we don't do clearance. 3 nodes positive, we do clearance.
I see.
Typically,
Should
it's
we
not
move
the
on?
Z11 criteria.
I think we should move on. We should move on to the last one because we have run out of time.
So the patient did a privately Oncotype DX with a recurrence score of 16. This translated to chemo benefit of 2.8%. She has had adjuvant chemotherapy with ET, Taxan, abemaciclib, ovarian suppression, and endocrine treatment. And this is our last question. Considering that she's T3 multifocal and 1 biopsy proven node positive and 2 negative, what would be the most appropriate management now? No further axillary treatment, only whole breast radiotherapy. The patient needs axillary node clearance and whole breast radiotherapy. The patient needs whole breast radiotherapy and regional radiotherapy to the axilla plus minus internal mammary chain.
Let's vote. And let's see the results now, please. Dr. Dimopoulos, what did you vote?
Of course, I voted for option number 3. So it is clear that we will not proceed with axillary lymph node dissection in this patient. And it is clear that we will have to treat the regional nodes and plus minus internal mammary. In that case, again, because we had multicenter disease, I think that and the positive lymph node, we will take into consideration to irradiate the internal mammary nodes. And finally, again, it's a very young patient. I think it's left-sided. And again, I would focus on the technique of radiotherapy. I would use, again, respiratory management.
Thank you. I think it was rather straightforward, the last question, I mean. Mr. Exarchos, thank you for your presentation. We were all impressed.
This is how the patient looks like now. Yes, she's had radiotherapy to the breast, axilla, and internal mammary chain with 15 fractions of radiotherapy with voluntary breath hold.
Bravo. Ωραία.
Michalis.
Yes.
Sorry, but I think that it is important not to leave the case with an oncotype results shown between the slides. Because we have to say that in this case, 42 years old, premenopausal, lymph node positive, there is no point of sending oncotype DX or MammaPrint. This patient is not going to have any help from genetic signatures because he clearly needs chemotherapy. Thank you.
I agree. The patient went privately and she did the oncotype DX just for her
What
peace of
was
mind.
the point? I mean,
Yeah, and
I agree.
obviously you didn't follow it, so yes,
Yeah.
yes.
I agree with Professor Markopoulos. Well, yeah.
Thank you,
Thanks,
George.
George.
Thank you for
Yes.
keeping the time. So let's move on to the next one. Thank you.
Okay, then we move to the fourth and last case of part one, but nevertheless not the easiest one. So we're gonna call Mr. George Metaxas now to talk about clinically node-positive breast cancer. How do we manage these cases these days, and what is the surgical planning? Obviously, it's not going to be a straightforward case, as you have already noticed. We're not going for straightforward cases. There are going to be some traps here, so be careful. George, the stage is yours.
Thank you very much, Sophocles, and I would like to thank the Hellenic Society of Breast Surgeons for the kind invitation. Can you actually see my screen?
Yeah, carry on. Just make it present. Yeah, okay, that's it.
Okay, so I'm going to be presenting a semi-fictional case. So this is a modified clinical scenario. So please try to focus on the scenarios and the questions and less maybe on the pictures that you will be seeing. So this is a 48-year-old female patient, premenopausal, who presented with a palpable lesion in the right breast, which had become obvious during the last 6 months. She never had breast screening before. She had no other past medical history, no previous breast surgery or biopsy, and a family history with a lung cancer from her father, and maternal grandmother ovarian cancer, and a maternal aunt breast cancer at the age of 30. On clinical examination, this is a C-cup size grade 2 ptosis patient with a palpable hard mass almost in the area of the right outer midline, measuring clinically about 3 by 3 centimeters, which feels also abnormal clinically. No changes on the skin, no nipple discharge, and also a palpable or a couple of palpable lymph nodes in the axilla with a size of almost 2 centimeters. In her mammogram, she had an architectural distortion with microcalcifications, which you can hardly see now, at the upper outer quadrant to midline, like an ill-defined mass within very dense breast tissue. She had an ultrasound scan which demonstrated an abnormal mass and a couple of abnormal lymph nodes in the armpit, also a further possibly abnormal but small lymph node measuring about 7 millimeter. So a mass about 25 millimeter and 3 possibly abnormal lymph nodes. She then had an MRI scan, which demonstrated a 34 millimeter irregular single mass in the same area of the breast and a couple of abnormal looking lymph nodes, plus or minus 1 further smaller lymph node. Her anatomic stage, the TNM stage, was at least at the time of presentation, clinical T2N1MX. So that is a clinical stage regardless the scenarios of 2B. So what is the next step? I am happy that we take it for granted, everyone, that a core needle biopsy of the lesion is taken for granted. So what else should we do? FNA from 1 lymph node, FNA from 2 lymph nodes, FNA from all 3 lymph nodes, a core needle biopsy from 1 lymph node, core needle biopsy from the biggest lymph node, and FNA from all other suspicious ones, or since grossly involved on imaging, no need for lymph node cytology biopsy, the patient would be suitable for axillary lymph node dissection only.
Okay, obviously here is the dilemma that we had a few years ago, whether we should biopsy all or some or one of the lymph nodes, the most suspicious one. And obviously there's another dilemma whether we do try to preserve the axilla even if we have a high cancer load in the axilla. So based on that, give us your opinion. What do you think is adequate in this case? Okay, shall we see the results, please? Okay, then, so it's split between the choices. As I said, there's no correct and wrong answers in this case, but I would like Vasilis, who a few years ago he was doing biopsy in all of the lymph nodes that he was seeing in the axilla, to tell us what he thinks about the voting now.
Unmute.
Unmute.
I think it's very interesting, the answers. I mean, choice 1 and choice 4, either fine needle aspiration in one lymph node or core needle biopsy in one lymph node. I will do core needle biopsy. I mean, I have all the informations from the core needle biopsy from the breast, and I will do only fine needle aspiration in one node and clip them.
Okay, so you have changed your opinion about making biopsies in all of the nodes in the axilla.
Yeah, I've changed that. I've changed that now.
Okay,
I mean,
Mr. Markopoulos, what do you think?
Well, I think that depends what you have in mind. If you're going for neoadjuvant, I would probably biopsy all the three in order to put a clip and try to see the results of the neoadjuvant. If you are going for upfront surgery, then clearance is more likely. So I would go for 6, though only 8% of people vote for that. If I have in mind operation, if I have neoadjuvant, then I would go probably for 5.
Bone needle biopsy from the biggest and an FNA from all other species. Okay, so George, you can carry on.
Okay, I think we had a very realistic answers in this case, in this question. So let's see the results of the biopsy. We have a grade 3 invasive ductal carcinoma, ER negative, PR negative, and HER2 negative, so a triple negative cancer with an 80 to 85% Ki67, and one proven positive lymph node, and one or two remaining suspicious ones because we didn't do a biopsy on them. So we choose answer number 4. We have a small stage migration, which may be relevant or significant. So the clinical prognostic stage would now be stage 3B, according to the latest categorization from 2B. So the patient had a CT and the bone scan, no distant mets, and blood sent for gene testing since he's a triple negative breast cancer. And the most appropriate next step is 1, upfront surgery. So that would be mastectomy or conservation plus axillary lymph node dissection. 2, neoadjuvant chemotherapy, no marker clip. 3, neoadjuvant chemotherapy clip in breast lesion. 4, neoadjuvant chemotherapy clip in breast lesion and biggest lymph node. And 5, neoadjuvant chemotherapy clip in breast lesion and all suspicious nodes.
Okay, so perhaps in here, everything broke. So we have an option between the most aggressive upfront surgery to the least aggressive upfront surgery, including neoadjuvant chemotherapy. So we have heard lots of speakers talking about this. I would like to see what you think right now after all these talks. I mean, there are different opinions from different centers and different surgeons. There's no right or wrong in this condition, I guess. Maybe one is less likely to be right. But let's see what you're going to vote. And can we see the results, please? Okay, so I'm happy that none voted for an upfront surgery. That means that we all right now know that we don't have to, or we must not go for upfront surgery in triple negative cancers that they are more than 2 centimeters or have positive axilla. So, and I'm glad to see that nobody voted for doing neoadjuvant chemotherapy without placing a marker clip. And that's very important because these are the 2 major messages that we need to pass in triple negative cancers. And at this point, I would like, who I would like? I would like.
Okay, make your choice.
I know Mr. Markoglou is going to say, but I will ask him to tell him his
No,
opinion.
Actually, it's what I said before. Having, if we had in mind beforehand the neoadjuvant, we should do 4 or 5, and now it's the only choice. So either 4 or 5, I agree, but personally, I would prefer again choice 5 because the two suspicious lymph nodes should be removed in the operation after the neoadjuvant, no matter what the result is, and especially if we have a complete pathologic response.
And that was one of the major discussions I had with Vasilis a few years ago. I would like to ask him now, what does he think? All or one?
What do you mean? 4 or 1, you said?
Oh, I said all of the lymph nodes to be
All
clipped,
or-
or one.
No, I will go for the number 4. Clip the breast lesion and the biggest or the lymph node that you've done the final aspiration or the core biopsy. I will go for 4.
Okay, I will ask a final answer from Corina. Corina, what do you think? You are muted. You're muted. You are muted, Corina. You have to unmute yourself.
Sorry, can you hear me now?
Yes, yes, of course.
I didn't ask the previous question, and because I wanted to stress that I would first like to know the kind of the lesion. I mean the immunohistochemistry of the lesion, and then would like to decide about what to do with the axilla and what to clip.
Negative.
In this one, I answered 5, because of course, if it's a triple negative, I would go for a neoadjuvant, but it would, if this would be a luminal A,
No, let's talk, Corina, well, let's talk about this case. Would you clip one or all of the lymph nodes? That's the question here.
I would clip more.
More. So we have 2 votes for more and 1 plus mine 2 for 1. So equally divided, I guess. Let's carry on to the next one.
Okay, I kept a screenshot of this because I think it's historically the first time that 100% of the surgeons have voted for no upfront surgery.
Yeah, I think that's a great success. Yes, carry on.
I don't remember any other similar. Okay, so let's say that post-neoadjuvant chemotherapy, in case of complete clinical response, that means clinically and by examination and by any type of imaging in axilla. So that means CNE 1 or 2 to CNE 0. The most appropriate management of the axilla will be axillary lymph node dissection, 1. 2, marked lymph node biopsy, so the clip node biopsy only. 3, targeted axillary dissection, i.e. the marked lymph node plus the sentinel nodes. 4, sentinel lymph node biopsy, dual technique, more than 3 lymph nodes to be excised. And 5, sentinel lymph node biopsy, no limitations.
Oh, please, you're muted.
Sorry. Okay. As I said, these are all correct answers, depending on the year that this voting will take place. If it took place 5 years ago, it would be completely realistic. If it takes place in 10 years, it's still going to be completely non-realistic. So just vote whatever you feel like. And I think there's a great debate in big congresses and always is divided. There's no clear answer about what's better and what's worse. So I'm quite curious to see the results. Can we see the results, please? Okay. So I think Tad is gaining grounds on anything else these days. So Urvashi, would you mind to give us an insight about this voting? What do you think?
I'm in agreement with this, and I'm actually quite pleased to see that most surgeons are moving towards de-escalation and that we have a consensus here. I think there is enough data now to suggest that the worry that we had initially with identification and false negative rate in this setting, we have an acceptable answer with all the data there is with adopting TAD Having said that, I think there is also data from MSKCC and European Institute of Oncology now to say that even if you did not clip or mark the lymph nodes beforehand, but you're able to excise up to 3 nodes with dual technique, which is option 4, you're able to get a reasonable false negative rate, and the follow-up of recurrences in these settings are very promising.
Exactly. So we get accumulated data from the literature. Whatever you do, it's right. And I believe in about 4 to 5 years, there's not going to be discussion about this technique. I think TAD is more complicated. I'm in favor of TAD, and I'm doing TAD. But I think eventually, I think we're going to end up in just doing a simple central lymph node in a few years. But for the time being, I think we should keep these numbers. And does anybody else wants to say something before we move on? I don't want to rush things. If somebody else wants to say something, I think we all agree that all the options are correct, I guess.
Marked lymph node or marked lymph nodes with that?
I think if we follow the initial description of TAD, I think it's one lymph node that they marked at that point. And I think most of the TAD studies, they're just marking one lymph node, the biggest and the largest one. And I think, well, both are correct. I mean, if you do one, you are covered. If you do more, you're more covered. Okay, it's not mistake more.
This is the right expression, actually.
It's not wrong to mark more. If you have the time, the money, and the patience to take them all out, it's not wrong. It's not wrong. It's definitely not wrong. I think the false negative rate, if you mark 4, is going to be 0%. So, shall we move on?
Actually, we improve the false negative rate, but probably we don't improve overall survival, as
Exactly.
Milan the other study show. The next one would be, sorry. So the decision for neoadjuvant chemotherapy, of course, clipping the breast lesion and the biopsied lymph node, negative genetic testing, neoadjuvant chemotherapy with pembrolizumab, doxorubicin, and paclitaxel, and patient had side effects, diarrhea, hepatitis, and hypophysitis. Patient had a complete clinical response, ultrasound and MRI for monitoring at the middle and end of neoadjuvant chemotherapy, complete MRI response in breast and axilla, and the mammogram at the end of the chemotherapy demonstrated a visible marker and some calcifications in the area of concern. So which is the most appropriate surgical management post-neoadjuvant chemotherapy? 1, mastectomy and axillary lymph node dissection. 2, mastectomy and senile lymph node biopsy or TAD. 3, wide local excision, removing the tumor footprint and axillary lymph node dissection. 4, wide local excision, removing the tumor footprint and senile lymph node biopsy or TAD. 5, wide local excision, residual tumor removal or clipectomy and axillary lymph node clearance. Wide local excision, removing the residual area, in this case the clip, and senile lymph node biopsy and or targeted axillary dissection.
Excuse me, Yorgos, for clarification, by residual tumor, you mean the microcalcifications as well?
No, I mean the uptake in the MRI scan or the ultrasound, which in this case was a complete response. We can still see, obviously, the calcifications left behind.
So if I want to remove the calcification as well?
That's the next question.
That's the next question.
Don't spoil the next question.
No, I wonder which one I would
Yeah, we're talking about visible tumor in MRI and ultrasound. And that goes for a generalized question. I think this is one of the questions that we need to sort out in the surgical community, whether we're removing more or less. I'll go back. So can we vote, please? And I would like, irrespective of the results, Mr. Kondoulis to discuss the results as soon as we get them.
So, just okay. So I think there is a debate for that case whether we're going to remove the footprint or the residual tumor only. Because we have some microcalcifications, there is a debate from the, let's say, German breast group analysis with 6,000 patients says that a residual DCIS may worsen survival rate, but all the other trials, like I-SPY 2 trial, have not confirmed that. So there is a debate. I would go for number 6. To remove the residual tumor plus clip and do TAD or sentinel node biopsy with more than 3 lymph nodes removed.
Yeah, I think Dr. Markopoulos said previously, what's the point of doing neoadjuvant chemotherapy if you're going to remove the initial tumor area? If you're going to do that, there's no point doing neoadjuvant chemotherapy, isn't it? So, Konstantinos Zachariadakis, would you mind discussing this one before we move on to the next one?
Yeah.
What would you do? Remove footprint, remove residual tumor? What would you do?
Yeah, sure. In principle, I agree with what you said. However, in this case, you do have extensive microcalcifications. So I would remove the initial footprint of the calcifications. So there's poor correlation between how calcifications change after neoadjuvant chemotherapy with pathological response. So in this case, like in a case without calcifications, I would definitely do a clipectomy, what you describe as a clipectomy, if I have a good response, or whatever tumor is left. I wouldn't remove the footprint. But in cases where there are also extensive calcifications, it's difficult to ascertain what is the correlation between the radiological response and the pathological response. And I think there's better correlation based on the MRI compared to the mammogram. So the residual calcs on the mammogram don't correlate that well with the pathological response. There's better correlation with MRI, but still it's not sufficient. And there was a meta-analysis that showed by Husami that showed that there isn't correlation.
Yeah, because you said that, we have this
that's
question
the
now,
next question.
obviously, and the next question is based exactly on the macro
Yeah,
calcifications.
interrupt with a question.
Yes, George, carry on.
My question is, what is the area of excision in case of having no residual disease? I mean, how do you define the area of excision in that case?
I'll go with the initial imaging. If you're going to resect the footprint, you go with the initial imaging and you remove exactly.
Most of the participants are voting for 6, which is the residual tumor plus the clip. And if you do not have any residual tumor, what is the excision you are performing?
We remove the area around the clip, and clinically, a lot of times you have fibrosis due to necrosis of the chemotherapy, so you have to remove that. Our point is that do we do that, or we go back and remove the original area of the tumor? However, this case is an exception because we have microcalcifications which certainly need to be removed. Oh, sorry, that's the question now. Yeah.
Shall we vote before we ruin the question? Shall we vote?
Yeah.
So the question would be, do all, sorry.
Yes, just read the question.
Do all visible microcalcifications need to be removed despite complete MRI response? Answer number 1, yes, all microcalcifications need to be removed. 2, no, acceptable to leave some microcalcifications behind if PCR on histology of main specimen.
That's still a tricky question because remember that the tumor is in the initial area of the clip and not in the whole area of the microcalcifications. So we remove something, that something came back as PCR, but we have some microcalcifications left behind. And the question is, are we happy with that? Or shall we go back and remove those calcifications? That's the question, the true question here. So let's see the results. Okay, most people believe that we have to go back and remove the rest of the calcifications if we haven't removed them initially. And some others believe that, no, we don't have to go back if we remove the initial specimen and came back as PCR.
No, that was not the case, Sophocles.
But I clarified the question. We took something, it came out as PCR, and then we...
No, this is a, sorry, Sophocles, for interrupting, but this is a different question. As the question is how what do we intend during surgery, at the time of surgery? It's not what we see afterwards, because if we, in time of surgery, we aim to remove all the calcifications, then we have to mark it and check it. If we are going to be based on final histology, and if we have clear margins, no indication of in situ in those calcifications, then it's a completely different thing, because we don't need to go back.
Okay, then.
So the
Let's
question is,
discuss it
what do
differently.
you need to do? Do
Okay.
you plan to remove them or not?
Okay, let's discuss it like that. Let's start by discussing whether we intend to remove them initially.
Yeah.
And Mr. Markopoulos, since you've started, obviously you and I would go for removing the microclassifications. And I agree with you, that would have been my plan. Does anybody else has a different opinion? No. Let's go back now.
Dr. Urvasi seems to have raised her hand.
Okay. Yes.
I just wanted to say that the microcalcifications and the tumor are a separate entity. If it was just the tumor and no microcalcifications, as Professor mentioned earlier, I would definitely just remove the area of the clip with with normal tissue around it. But if there are microcalcifications, then those need to definitely be taken into account and excised. So I think they are both different entities.
Yannis Natsiopoulos, would you mind switching on your camera and give us your opinion?
Good morning to all of you. It has to do with the primary biopsy. If there is any DCIS component in the primary biopsy, that means that microcalcifications has to do with DCIS. Maybe primarily we have to biopsy the tumor apparent on ultrasound, and also stereotactic biopsy of the microcalcification. So we have to do this to take a decision precisely in the first operation. Thank you.
I agree with you, but because this case is simple case, very short area, but imagine somebody who has 3 or 4 centimeters calcifications. So I think Yannis's point is quite okay. And let's go to the next question, please, because we're running out of time.
Just a small comment that with
Yes, yeah, definitely.
therapy, we eliminate cancer cells, but not calcifications. And there are studies that demonstrate that the fact that you have calcifications in an area after neoadjuvant chemotherapy doesn't correlate definitely with the fact that there is remaining cancer there.
Yeah, that's true. That's why I ask whether anyone of us would go back if we had remaining calcifications. Carry on, Josh.
Let's say this woman had a wide local excision, a clip and area around, and sentinel node biopsy and TAD, including the markers. She had a PCR, no invasive cancer, no DCIS in the breast and the lymph nodes. And she had a total of 0 out of 3, so 1 marked lymph node negative and 2 sentinel nodes negative. And a similar, whilst in the beginning she had the triple negative, as we remember, invasive ductal carcinoma with a high Ki67. So complete response, pathological response. So considering the pre-neoadjuvant chemotherapy axillary status, at least 3 suspicious or almost 3 suspicious nodes, and the results of TAD 0 out of 3. 1, this patient needs axillary lymph node dissection. 2, needs radiotherapy to the axilla, supra and infraclavicular areas. 3, she needs whole breast radiation. No further management of the axilla is necessary, just observation.
Obviously, some questions are repeated because different speakers prepare those. But nevertheless, we need to see how the opinions are changing during the webinar. So let's vote. I think there's not going to be much discussion on this one. We have discussed that previously. So let's see what everybody believes here. So the question is whether we're doing what we're going to be doing in 10 years or what we're going to do if we're going to do what we're doing now. Complicated sentence, what I said, but this is the point. So shall we see the results? So most people follow the NCCN guidelines, and 1/3 of us believe that the study of Mamounas et al. Is going to be the point now and in the future. And a short comment by Mr. Dimopoulos.
Yeah, again, I mean, this in terms of radiotherapy, this is a mirror case to case 1, which means that it's a case of CN1 which converted to N0. So the right choice is again question 2, and this is what we have in the guidelines nowadays.
Okay, I agree with you. We have to inform the patients if we're going to do something out of the guidelines. This is my opinion. And would also like to ask somebody else who agrees with me or who disagrees with me, preferably, to say his or her opinion. Anybody who would have gone for no radiotherapy without informing the patient about the lack of evidence? Kostas Zacharidiakis? We can't hear you, although you're not muted.
Hear me now.
Yes, yes.
There's no option that with no radiotherapy in the questions.
Is the last one. It's just
whole breast radiotherapy, no further management of the axilla, just observation.
Yeah.
Well, I would like to ask Dr. Dimopoulos, what are the
I cannot hear you. I cannot hear you.
Yeah, just get closer to the microphone.
Yeah,
You're
sorry.
far.
Yeah. N1 disease, you would always give regional node radiotherapy. You wouldn't give it to N2 disease. Is that correct?
Yeah, I think this is a suggestion we have now at the moment.
Okay. All right. No.
Okay, so
we would usually offer radiotherapy to areas outside the axilla. It depends. There are many different factors, obviously, but probably this patient in our MDT, she would have whole breast radiotherapy only, without any radiotherapy to the supraclavicular fossa if we thought it was like 1 to 3 nodes.
Of course, there are different strategies. There are also high tangents, which are treating level 1 and 2 and excluding supraclavicular nodes. And it depends also on the technique. So if you use conformal techniques, you're also radiating the axilla. And in case of using advanced techniques like IMRT, you have to include them because they are not always treated. So, but the suggestion I think at the moment is that even if you have one positive node, to treat the regional lymph nodes, and these are the results in case of having lumpectomy. These are the results of the M820 trial. They're in favor of treating regional nodes. And what we have here is we have TAT. We do not have any axillary lymph node dissection. I mean, the trials we have are using the former trials. In these trials, all patients had axillary lymph node dissection.
Yes. I think we can carry on. I agree that we still need to get more data to go to abandoning the radiotherapy to the axilla for the time being. As Dr. Dimopoulos said, the guidelines say radiotherapy to the undissected part of the axilla at least. So shall we carry on?
This patient actually had a completion clearance with a further 8 lymph nodes, which were clear, so a total of 0 out of 11 lymph nodes. So now the question is, the patient needs whole breast radiotherapy and 1, no further management, 2, radiotherapy to the non-dissected part of the axilla and regional radiotherapy, and 3, radiotherapy to the non-dissected part of the axilla only.
So more or less is the same question as previously, the discussion whether or not we need to irradiate more or just stick to the axilla. And obviously that depends on the institutions and the studies. Let's see the voting. Let's see the results, please. Okay. So still there is 18% that believes that no further management is enough. And most likely in a few years, they're going to be right. and all of us would change the opinion. 62% they're going with the guidelines, so they're irradiating everything, and 20% they stick in between, just radiotherapy to the non-dissected part of the axilla, which is something between. I want only a short comment, maybe from Thodoris, about the third option, not from anything else. We have discussed everything else, so I don't think we have to stick with that. To the third option. Any...
No, I agree that with you that if we take into account B51, we will not do radiotherapy. I have a question to George Metaxas. What's the rationale of doing TAD if we have decided to do clearance?
So there is, please, we don't discuss the case. We just, if it's possible, because we can't comment on that. This is what happened for somebody else. So we don't comment on that. We comment only on the radiotherapy at this point.
Radiotherapy, I think that number 3 is, for me, is correct, not to do radiotherapy at all at this point.
Okay. Dr. Margoudakis, are you with us?
No.
Yes, I am.
Your opinion about only number 3. Your opinion about number 3.
Yes, this is what I prefer, actually. I'm very reluctant about the side effects, though they are not very common, but they're still side effects if we are very extensive in radiating all the areas. So I would prefer to irradiate the non-dissected part of the axilla. I know I'm out of guidelines, but we have to evaluate the risk and the benefit. And in this case, I think that it is the best solution to do only to the non-dissected part of the axilla only, though I know I'm out of the guidelines.
Thank you very much. So we heard everything about the radiotherapy. I think we covered that. And let's go to the final question. George, carry on.
Yes. Adjuvant systemic treatment post-surgery, considering the histology and the side effects of pembrolizumab, this patient should restart pembrolizumab post-operatively, or 2, this patient, pembrolizumab should be stopped. Because
remind you that the patient had a severe complication, the hypophysitis, diarrhea, so more or less it was not very tolerable, the pembrolizumab by the patient. So are we going to continue with that medication, or are we going to stop using it? And obviously, Dimitris is going to discuss this one.
Okay.
And close the session. Wait. We have to get the voting results first before you discuss it. So shall we see the results? Okay, 83% voted to stop it. What do you think?
So immunotherapy can cause this sort of side effects. Hypophysitis, unfortunately, is usually non-reversible. So this patient ends up getting thyroxine and steroids lifelong. But providing we are supplementing those, if we feel that it is necessary to continue pembrolizumab, she can. This is not a reason for discontinuation. So the grading of diarrhea and hepatitis are reasons to discontinue pembrolizumab. So if she has grade 2 and up, then we discontinue. But if it was only grade 1 or grade 2 and quickly resolved to grade 1 and 0, then she can continue pembrolizumab, which, as we know, benefits both people who get a PCR and those who don't achieve a PCR.
Okay, thank you very much.
So just a quick comment, the neoadjuvant treatment incorporates carboplatin as well, which was not mentioned. And although she was BRCA1 and 2 wild type, she has a very suspicious family history. Of course, this is a fictional case, but in real life, we would check and update our BRCA testing and consider panel testing in this patient.
Okay, thank you very much for your input. And thank you everybody for discussing all these cases. So we are only 5 minutes behind, and that's a great success. So we beat the first enemy, and we also most likely beat the other enemy, the weather, because a lot of people attending the course. So the next step is going to be, we have a half an hour break, lunch break, but during this break, we're going to have 2 pre-recorded satellite symposiums. The first one is going to be about EndoPredict, the advantages of the second generation gene expression test by Claire Jackson. And the second one will be the Oncotype DX presented by Yorgos Kapetsis. So enjoy your lunch. It's in front of your screen. There's going to be lots of interesting things to hear about the genetic signatures. And we're going to be back, according to this, in about half an hour, which would be 1/4 Instead of 10 past, it's going to be 1/4. Thank you very much for attending. And shall we carry on with the pre-recorded, please? You.
Hello, my name is Claire Jackson. I am the Clinical Affairs Manager for Myriad International. Thank you for the opportunity today to present some of the key data for the gene expression test EndoPredict. My presentation will briefly cover an overview of the test and then focus on use in premenopausal setting and the prediction of chemo benefit. EndoPredict is a second-generation gene expression test developed specifically for the ER-positive, HER2-negative, node-negative and positive target population. Tumour gene expression is calculated and reported as a 12-gene molecular score, sometimes referred to as the EP score. This is then combined with the clinical parameters tumour size and nodal status to produce the EP-CLIN risk score. The EP-CLIN risk score is reported as a binary high risk, low risk result with only one cutoff to consider, predicting both early and late recurrence out to 15 years. It is important to note that EndoPredict is run locally and reimbursed in Greece. The EndoPredict report is a multi-page report providing 3 pieces of information individualized for the patient to aid in treatment decisions. An example of the first page is shown here for both the low-risk patient in green and high-risk in blue. The summary at the top of the report details the patient's clinical information, EP-CLIN risk score and risk class. The bottom section summarises the 3 pieces of individualised information and is organised by treatment planning stage. Firstly, what's the risk of recurrence in the next 10 years? Can the patient avoid chemotherapy? And what is the absolute benefit from chemo? And thirdly, what's the risk of recurrence in years 5 to 15 after 5 years of endocrine therapy without recurrence? Can she safely avoid extended endocrine treatment? The detail for these is then provided on the subsequent pages of the report. This slide provides an overview of the training validation roadmap for EndoPredict. The key point to take from this table is that EndoPredict has been validated in 6 independent prospective retrospective studies in over 5,000 patients with ER-positive, HER2-negative breast cancer, both node-negative and node-positive. The aim of the 6 studies was to show that the test could predict distant recurrence and significantly add information to standard clinical pathological factors. By combining the 12-gene molecular score with nodal status and tumour size, in all studies, the EP-CLIN risk score consistently identified breast cancer patients with very low risk of 10-year distant recurrence, ranging from 0 to 5.8%. These studies together form level of evidence 1B, further confirmed by the prospective study with LOE 1A. One component I would like to highlight is the selection of tumour size and nodal status as the clinical features included in the EndoPredict result. In one of the early validation studies, the relation between the EndoPredict 12-gene molecular score and distant recurrence was assessed by Cox models adjusted for the variables shown in the table. In both data sets, the only independent predictors of distant recurrence were tumour size, nodal status, and the 12-gene molecular score, the 3 variables which make up the EP-CLIN risk score. It is important to note that age and, as I'll show in the following slides, menopausal status were not prognostic of outcome. So, there is much discussion around the use of gene expression tests to support the use of chemo in the younger premenopausal patients. I would like to take you through the data for EndoPredict in this patient group. EndoPredict is validated in both pre- and postmenopausal women. But to further confirm utility in younger patients, this study, led by Anastasia Konstantinidou of Cyprus, specifically evaluated the performance of EndoPredict in 385 premenopausal patients. Samples were collected from unselected patient cohorts who were premenopausal at the time of diagnosis and systemically treated with adjuvant endocrine therapy alone. The primary objective asked is EP-CLIN risk score prognostic of 10-year distant recurrence in a premenopausal population. The median follow-up was 9.7 years. To answer the primary objective, this slide shows distant recurrence-free survival for the EP-CLIN high and low risk groups. 65% of the total study population were classified as EP-CLIN low, and as shown in green on the graph, had a low 10-year distant recurrence of 3%. This was significantly lower than those classified as EP-CLIN high, with a 10-year distant recurrence of 24%. Thus, with a median follow-up of 9.7 years, EndoPredict was shown to be prognostic of 10-year distant recurrence in premenopausal women who received adjuvant endocrine therapy alone. Further analysis evaluated outcome in the node-negative and node-positive subsets. The evaluation showed that EP-CLIN risk score was strongly associated with 10-year distant recurrence-free survival, regardless of nodal status, as shown here with 3% and 0% recurrence in the node-negative and node-positive subsets respectively. Thus concluding that EndoPredict identifies premenopausal women with low-risk breast cancer who may safely forgo adjuvant chemotherapy, independent from nodal status. To determine if the EP-CLIN score was prognostic independent of other clinical factors, a multivariate model was used. As shown in the table, EP-CLIN score was the only factor significantly associated with risk of distant recurrence, with 10 years of diagnosis, independent of age, tumour grade, Ki-67 and hormone receptor expression. The premenopausal study is further supported by an independent prospective registry at the Technical University Munich, Germany, that provided the first prospective outcome results for patients whose adjuvant systemic therapy recommendation was based on the EndoPredict test result. 368 women with HR positive, HER2 negative, node negative and node positive early breast cancer, of whom 1/3 were premenopausal, were enrolled in the routine clinical setting between 2012 and 2015. The results overall found that patients classified as EP-CLIN low risk had over 96% distant metastases-free survival at 5 years. Conversely, EP-CLIN high-risk patients had only 85% distant metastases-free survival, demonstrating they were significantly greater risk than patients with EP-CLIN low risk. This slide shows the 5-year distant metastases-free survival results by menopausal status. Almost 2/3 of both pre- and postmenopausal women were classified as low risk. In both the pre- and postmenopausal subgroups, patients with an EP-CLIN high-risk result, as shown in blue, were again at significantly greater risk of experiencing distant metastases compared to those with an EP-CLIN low-risk result, shown in green. This demonstrates the ability of EndoPredict to identify patients who may safely avoid chemotherapy, regardless of menopausal status. And this prospective analysis confirms the results of the premenopausal study shown previously. Another topic often debated is the ability of gene expression tests to predict chemotherapy benefit. To investigate whether the EndoPredict test can predict chemotherapy benefit, a retrospective non-randomized cross-cohort analysis was carried out in pre- and postmenopausal women treated with endocrine therapy alone or endocrine therapy and chemo using data from 5 large clinical trials. The primary endpoint was distant recurrence-free survival. This graph shows the relationship between EP-CLIN risk score and 10-year risk of distant recurrence for endocrine therapy with or without chemo. As EP-CLIN risk score increases, women receiving endocrine therapy alone, shown in blue, have a greater 10-year risk of distant recurrence compared to those on endocrine therapy and chemo, shown in green. For example, women receiving endocrine therapy alone with an EP-CLIN risk score of 5, as shown by the arrow on the graph, had a 10-year distant recurrence risk of 46%, compared to 26% for women who received chemotherapy. In contrast, no differences in 10-year risk were observed for low EP-CLIN risk scores, i.e. those who are at low risk of recurrence. In testing the statistical strength between chemotherapy benefit and EP-CLIN risk score, an interaction test between treatment selection and EP-CLIN as a continuous variable was statistically significant. Overall, the data shows us that patients with a low EP-CLIN risk score did not benefit from chemotherapy, while those with a higher risk score had a greater benefit from chemotherapy. Looking at these results in terms of absolute and relative benefit of chemotherapy, in this analysis, in each group, recurrence risk increases as EP-CLIN risk score increases. Patients with a high EP-CLIN risk score who received chemo had lower recurrence risks than patients with endocrine therapy only. Absolute benefit of chemotherapy increases with EP-CLIN risk score, as does relative benefit, demonstrating an overproportional benefit. The investigators concluded that although the approach was an indirect comparison of EndoPredict in women treated with chemo plus endocrine versus endocrine therapy alone, they demonstrated that a high EP-CLIN risk score can predict chemotherapy benefit in this patient group. More recently, in the Technical University Munich prospective analysis I briefly discussed earlier, investigators assessed those patients classified as EP-CLIN high risk by treatment received. Of the 130 patients classified by EndoPredict as high risk, 2/3 received chemotherapy while 1/3 declined. The graph on slide shows the rate of disease-free survival according to treatment received. Patients who received chemotherapy, shown here by the dark blue line, had a significant benefit at 5 years versus those who chose not to receive chemo. Almost 90% of patients were disease-free at 5 years versus only 70% of the non-chemo group. The authors concluded that patients categorized as EP-CLIN high risk benefited from adjuvant chemotherapy. This prediction of chemotherapy benefit in a prospective study confirms that seen in the retrospective comparative analysis shown on the previous slides. To further support the data from the key EndoPredict validation studies, there are additional prospective studies ongoing. It is anticipated that the results of the first 3 studies shown here, Charité, TUM and UniRad, will be published this year. The 4th, Rescue, is ongoing with first results due in 2026. Finally, I would like to summarise the position of EndoPredict in the guidelines. EndoPredict is supported by multiple key national and international guidelines, including ASCO, NCCN, St. Gallen and ESMO, in both node-negative and positive patients, and importantly in Europe, irrespective of menopausal status. It is also worthy of note that the chemopredictive studies for EndoPredict are acknowledged within the ASCO guidelines publication. Most recently, the ESMO Clinical Practice Guidelines for early breast cancer were updated and published in Annals of Oncology at the end of 2023. It is worthy of note that the ESMO Guideline Committee now recognise that the level of evidence for use of gene expression assays in the adjuvant setting is 1A, and that the guidelines apply for all tests without any assay preference, confirming the recognition of robust study data for second-generation options like EndoPredict. To drill down further on the guideline, this slide shows the chemotherapy section within Supplementary Table 5. The first thing to note is the ESMO guideline now gives recommendations for both pre- and postmenopausal patients. And as standard, genomic tests are recommended for use in intermediate risk patients. Finally, I'd like to highlight the high and low risk categories included in the named genomic tests. Low risk includes EndoPredict low, MammaPrint low or ultra low, Oncotype less than 15, i.e. low only, and Prosigna less than 60, which is low and intermediate. High risk includes EndoPredict high, MammaPrint high, Oncotype greater than 26, i.e. Oncotype high only, and Prosigna greater than 60. Notably, the guidelines exclude Oncotype RS 16 to 25, the intermediate risk category. This underscores that the Oncotype mid-range data has not provided conclusive evidence and emphasises the importance of clear risk distinctions. EndoPredict provides precise categorisation into high and low risk groups only. So to summarise, EndoPredict is trained and validated in over 5,000 pre- and postmenopausal women. With both retrospective and prospective data, we've confirmed that EndoPredict can accurately identify patients who may safely avoid chemotherapy, regardless of menopausal status, and predict chemotherapy benefit in women with ER-positive, HER2-negative disease. Thank you for your time today, enabling me to present important aspects of the data for the EndoPredict test. I hope the content has been of interest and that EndoPredict can support you and your patients in the management of their breast cancer.
Greetings, everyone. Firstly, I would like to extend my sincere gratitude to the organizing committee for the opportunity to discuss today about the groundbreaking advancements brought forth by Oncotype DX. Let me start by saying that nowadays it is widely acknowledged that the majority of patients with early-stage breast cancer have little or no benefit from chemotherapy. Taking into account the negative impact of chemotherapy on quality of life due to both short and long-term side effects, there is an imperative medical need to distinguish patients between those that benefit from chemotherapy and those who don't. For that cause, molecular assays, also called gene expression assays, have been developed and contributed to improved risk stratification compared with clinical pathological factors alone. Before diving into more details about the oncotype, I would like to point out the difference between two terms, which unfortunately, even in today's clinical practice, there is a misconception of them. The first term is prognosis, and we are talking about a prognostic biomarker when it informs us on clinical outcome independent of treatment received. The second term is prediction, and we are having a predictive biomarker when it informs us on the response to a specific treatment, for example, chemotherapy benefit. Several prognostic factors are considered when deciding on appropriate adjuvant therapy, like age, tumor size, tumor grade, nodal status, HER2 status, ER/PR status, and multigene assays. However, from all these factors, those that are both prognostic and predictive are ER status for endocrine therapy, HER2 status for anti-HER2 targeted therapy, and the Oncotype test for chemotherapy. And the clinical indication of Oncotype is for newly diagnosed early-stage invasive breast cancer, HR-positive, HER2-negative, node-negative, N1 micrometastatic or N1 disease. There is a long history of clinical trials supporting the clinical validity and utility of Oncotype. The prognostic value of the test was retrospectively validated in the clinical trials NSABP B14 and TransAttack. The prediction of chemotherapy benefit was retrospectively validated in prospective trials NSABP B20 for node-negative and SWOG 8814 for node-positive disease. Most importantly, we have these two prospective randomized clinical trials, TAILORx for node-negative and RxPonder for N1 disease, that further refined chemotherapy benefit. Oncotype is the only multigene assay validated for prediction of chemotherapy benefit in prospective randomized clinical trials where we have two arms that there is a straight comparison between endocrine therapy plus chemotherapy versus endocrine therapy alone. The data from all these clinical trials and additional data from registries like the SEER registry from National Cancer Institute in the United States of America and the Clalit registry from Israel add to the impressive body of evidence for Oncotype, making it the most well-studied molecular assay. And starting from node-positive patients with 1 to 3 positive lymph nodes, and discussing about the RxPonder, The purpose of this study was to further refine chemotherapy benefit estimates in HR-positive, HER2-negative, N1 early breast cancer patients. In the study design, patients with a recurrence score over 25 were excluded from the study, and it was recommended that they receive chemotherapy followed by endocrine therapy. Those with a recurrence score 0 to 25 were randomized to receive endocrine therapy alone or chemoendocrine therapy. The primary objective of the study was to determine the effect of chemotherapy, if any, on invasive disease-free survival, with adjustment for menopausal status. The initial results were presented in the San Antonio Breast Cancer Symposium back in December 2020. Looking at the overall population of the patients in the study, there was a 1.2% benefit of chemotherapy addition to endocrine therapy in the 5-year invasive disease-free survival. 1 year later, in 2021, we had the updated results with a median follow-up of 6.1 years. And in terms of menopausal status, for the postmenopausal population, the addition of chemotherapy to endocrine therapy did not result into benefit on any endpoint reported. A subsequent subgroup analysis did not identify any group of these patients who might benefit from the addition of chemotherapy. So, at this point, it's pretty clear that postmenopausal patients with a recurrence score 0 to 25 do not appear to derive a benefit from chemotherapy. In contrast, in the premenopausal population, women with a recurrence score 0 to 25 showed a modest 2.4% benefit from chemotherapy addition in terms of distant recurrence-free interval and a 4.9% benefit regarding the invasive disease-free survival. In the forest plot analysis of premenopausal patients in our exponder, we can see that nearly all subgroups derived a benefit from chemotherapy, with the exception of those over 50 years old or those with lobular subtype. And now moving to node-negative patients. This is the study design of TAILORx. Over 10,000 patients were recruited to the trial, and they were initially divided into 3 groups as a result of their recurrence score. Based on the retrospective data from the prospective trial NSABP-B20, patients with a recurrence score 0 to 10, which was arm A, were assigned to endocrine therapy alone, whereas patients with a recurrence score over 25, arm D, were assigned to chemoendocrine therapy. The experimental group of the trial consisted of patients with a recurrence score 11 to 25, and these patients were randomized to receive endocrine therapy alone or chemoendocrine therapy. The initial results for groups B and C were presented in the plenary session of ASCO in 2018. The primary endpoint of the trial was fulfilled and showed that endocrine therapy alone was not inferior to chemoendocrine therapy in patients with a recurrence score of 11 to 25 regarding invasive disease-free survival. Following the initial results, there were some exploratory analyses carried out that did reveal some interesting trends. Today, we have TAILORx data after 12 years of follow-up. Taking into account the age of the patients and setting a cutoff of 50 years old, we can see here that for patients younger than 50 years old and a recurrence score 16 to 20, the estimated absolute chemo benefit is 0.6%. However, if we incorporate the clinical risk of the patients, in case of high clinical risk, then the estimated absolute chemo benefit reaches the 3.1%. Likewise, for patients with a recurrence score 21 to 25, the estimated absolute chemo benefit is 7.8%, and in case of high clinical risk, it reaches the 11.7% of benefit. So, putting all these results together, we can see that women with node-negative, over 50 years old, and postmenopausal N1 patients appear to derive no benefit from chemotherapy when the recurrence score result is 0 to 25. For women younger than 50 years old, there is no chemotherapy benefit for recurrence score 0 to 15, and then for recurrence score 16 to 20, 0.6%, and recurrence score 21 to 25, 7.8%. Lastly, for premenopausal N1 patients, there is a modest chemotherapy benefit for recurrence score 0 to 25. Another interesting feature of the 12 years of follow-up results from the prospective randomized clinical trial TAILORx is the observance of the phenomenon of late recurrence, which characterizes the ER-positive, HER2-negative disease. If we focus on the distant recurrence-free interval in the upper right diagram, the bars in the orange color represent the events after 12 years follow-up, and the bars in the gray colors, the results after 5 years of follow-up. The distant recurrence in the first 5 years was of 2%, whereas between 5 and 12 years, there were 5%, leading to a total 7% of distant recurrence events. It is obvious that late recurrence outpaced earlier recurrence. And what it is quite interesting is the fact that we have prospective data to support that the addition of chemotherapy did not alter the outcome, as both arms B and C demonstrate the same pattern. The implementation of Oncotype test in clinical practice can identify patients who might got overtreated or undertreated if clinical risk alone determined the treatment. Specifically, in TAILORx, 73% of patients with high clinical risk had a recurrence score result of 0 to 25, and otherwise they might have been overtreated. Again, in TAILORx, 43% of patients with the recurrence score results 26 to 100 had low clinical risk, and these patients might have been undertreated if decisions had been made without the Oncotype test. Now, I would like to present you the guideline recommendations regarding gene expression assays. As stated in the most recent NCCN guidelines, Oncotype is the only test with proven predictive value regarding adjuvant chemotherapy. It is recognized as the preferred option for node-negative and postmenopausal N1 patients with HR-positive, HER2-negative early breast cancer. It is also characterized by the highest level of evidence, level 1, and it is important to note that MammaPrint also has a level of evidence 1 due to the prospective MINDACT study. However, MammaPrint has only prognostic value validated. After the results of RxPonder were presented in 2020, the NCCN guidelines in January 2021 for the first time separated in its guidelines breast cancer patients in pre- and postmenopausal groups in consideration of systemic adjuvant treatment in HR-positive, HER2-negative disease. For postmenopausal, node-negative, and N1 patients, Oncotype is the only multigene assay strongly considered for use. It is referred that other prognostic gene expression assays might be considered to help assess risk of recurrence, but have not been validated to predict response to chemotherapy. Again, for premenopausal patients with node-negative disease, only Oncotype is strongly considered for use. Again, all the other prognostic assays have only prognostic value, and it is also referred that in premenopausal patients with a recurrence score below 26, the addition of chemotherapy to endocrine therapy was associated with a lower rate of distant recurrence compared with endocrine monotherapy. But it is unclear if the benefit was due to the ovarian suppression effects promoted by chemotherapy. In premenopausal patients with 1 to 3 positive lymph nodes, no gene assay is strongly considered as the preferred option, and their use has only prognostic value. Again, the same comment about those patients with a recurrence score below 26 and the chemotherapy benefit. Looking at the ASCO algorithm on biomarkers to guide decisions on adjuvant endocrine and chemotherapy, for patients with HER2 negative, ER positive, in premenopausal patients or age below 50 years old, for node negative, Oncotype is the only test referred with the highest quality of evidence and strong strength of recommendation. In case of node positive, there is not insufficient evidence to recommend a biomarker for use. And for postmenopausal or over 50 years old patients in node negative disease, Oncotype DX again has the highest quality of evidence and the strong strength of recommendation. MammaPrint follows with intermediate quality of evidence, and then we have the other assays, EndoPredict, Prosigna, with intermediate quality of evidence and moderate strength of recommendation. And in node positive patients with 1 to 3 positive, 1 to 3 lymph node positive, Oncotype DX again, highest quality of evidence and strong strength of recommendation. And then we have MammaPrint with intermediate quality of evidence, and it is in the same level of evidence with KI67. And then we have EndoPredict with the lower rate with intermediate quality of evidence. Now, all these guidelines and health technology assessment body recommendations position Oncotype DX test as the preferred assay. And lastly, I would like to point out that multigene assays are not the same, and they do not provide the same information. So, every time we must follow the evidence and ask ourselves the following questions. Has the test predictive of chemotherapy? Is the test predictive of chemotherapy benefit? Is it prognostic? What is the clinical utility of the assay? Does it have prospective outcomes evidence? What is the level of this evidence? And is the assay incorporated in treatment guidelines? I would like to thank you for your attention.